on the content. So like this we had, then people suggested we should have the time, and there was some error on that. I apologize for that. And this will be 2 cases for the day. We'll have surgical jaundice presented by Dr. Reshmi Mani from KIMS Hubali. And we have Dr. Ram Krishna from National Municipal Corporation, Delhi Medical College, New Delhi, presenting on a case of breast lump. And we have a very impressive array of invited faculty for the day. Professor Siddharth Pramod Nubashi he's the head of the department from Alya Institute, Nagpur, Maharashtra. Thank you, sir, for joining us. And in fact, credit, I think Prabal gave the introduction to Siddharth, sir. I've seen him in many conferences. Personally, I don't know, but then thanks to Prabal also for introducing. And
thank you for the opportunity. Yeah.
Thank you, sir. Professor Jatin Bhatt is from PDU Medical College, Pandit Deen Dayal Upadhyay Medical College, Rajkot, Gujarat. Again, I thank Professor Hitesh Andaria, sir, for giving the connect. Thank you, sir. Thank you. I think Jatin Bhatt, sir, should shortly join. And thanks to, again, Dr. Rajgopal, sir, and Dr. Gurushatampa for introducing Professor Ishwar Hosamani. In fact, his department PG is presenting one of the cases. And again, I think we are going to shortly have this faculty also is having the joint connectivity challenge. Professor Kannan from Mahatma Gandhi Medical College and Research Institute, Puducherry. So with this being the faculty panel, and I have the entire galaxy of people, and many have joined in. So I'm not sure how I'm going to make this, but I'm sure people who are regularly coming in will be added up to this panel. Feel free to join. Sanjay sir said he'll be joining little later. All others are there with us. And this is a streamlining work which I've done so far so that it becomes easier and standardized. I'm not sure whether I'll be able to create a permanent ID for Zoom at this point of time. But YouTube channel is standardized, mail for PGs is standardized, and when you don't have a internet to join us, you can use your mobile phone to dial this number so that you can listen to that whatever class we are taking. So people who have a challenge in connectivity need not worry. They can just connect to your phone. This can be dialed from any mobile or landline so that you can join the class dialing this number. So at this point, I still have challenge of the Zoom ID. Zoom ID at this point, it is open access, but I think let me see next week what are the changes the Zoom people are bringing in. Once they are coming in, I think I'll be able to standardize that also. So people can on time join the classes, whatever day it may be. So with that, I thank the faculty and the postgraduates who have joined for the day. So we'll have the first case, surgical jaundice, to go. Can I have Dr. Reshmi Mani switch on your video, doctor? I'm sorry, Reshmi Mani, you're okay?
Sir.
Yes, perfect, perfect. I think we have Dr. Jatin Bhatt with us. Good afternoon, sir. Good afternoon, sir.
Yeah, good afternoon, sir. Hello, how are you?
I think we are okay. Thank you. Thank you. Thanks for everything. As usual, the pattern will be the student will be allowed to present the history in full. Discussions in relation to history will happen after the summing up of history. Then again, we go through the clinical process. After the diagnosis, the initial part of discussion will be revolving around the clinical finding. Then we move on to the other management issues as such. So this will be the plan. Then we will have the primary importance to today's faculty first, and then later the other seniors can chip in or intervene or whatever. So the priority will be for today's faculty. Then senior faculty who are always with us can definitely chip in and advise. So with that, I request Reshmi, I think you can start sharing. Please introduce yourself, and you also should introduce about your department and your unit chief. Then go ahead with the presentation. Faculty, please take over. All yours.
Can you see the slide, sir?
We are okay, Kana. Start. All the best.
Thank you, sir. Good afternoon. Myself, Dr. Ashmi Mani, final year postgraduate, Department of General Surgery, KIMS Hubli. My guide being Dr. Ishara Rosmani, Professor and Unit Chief, and my HOD is Dr. Gurshant Tappayagaj. Hereby, I am presenting a case, Mr. A, 35-year-old male, who is a coolie by occupation, hailing from Anumatti, Koppal district. He came with the chief complaints of pain abdomen since 3 months, mass per abdomen since 3 months, and weight loss since 3 months. Coming to history of presenting illness, patient was apparently all right 6 years back. Then he developed a pain abdomen, which was insidious in onset, intermittent type, 5 to 7 episodes per year, pricking in nature, more in the upper abdomen, radiate to back, which precipitates after a binge of alcohol and relieves after medication. This pain was not related to food intake or not associated with vomiting. Now, this pain has been increased in both intensity and severity since 3 months, which is of cramping type now, more in the central and the right side of upper abdomen. It radiates to back. Now it aggravates even on exertion and after food intake, relieves partly on medication. Patient is also complaining of mass per abdomen since 3 months on the right upper part of abdomen, which is insidious in onset, gradually progressive. Initially, it was of small size, now progressed to current size. It's associated with pain, which is of colicky type, which occurs immediately 10 to 15 minutes of food intake and lasts about 2 hours, and it is also not associated with vomiting. He also gives history of early satiety or loss of appetite since 3 months. There is a significant weight loss since 3 months. There is a history of passage of eye-colored urine and a clay-colored stools since 2 months. He gives history of yellowish discoloration of eye since 1 month, which is noticed by his family members. It is progressive, there is no waxing and waning, and it is not associated with itching. The history of fever since 1 month, which was insidious in onset, mild degree, not associated with chills and rigors, which relieves on medication. This history of even easy fatigability and generalized weakness since 1 month. There is no history of any passage of black tarry tools, that is melena, or bleeding or rectum. There is no issue of any vomiting or emetemesis or altered bowel habits. There is no history of even blood transfusion previously. No history of any chronic drug intake or any previous hospital admissions for the above pain management. There is no history of any breathlessness or cough with expectorations. For these above complaints, he consulted some local hospital in Koppal 1 month back, where he has been referred to our KIMS hospital for further management. Coming to past history, there is no history of any surgeries in the past, no history of jaundice or any recent onset of diabetes, no history of tuberculosis or any malignancies. Family history, there is no history of similar complaints in the family members, no history of malignancies in the family members. Coming to personal history, patient consumes a mixed diet. Now his sleep has been disturbed because of pain. The appetite has been reduced. He passes eye-colored urine and clay-colored stools. He is a chronic alcoholic since 15 years, consumes 1 quarter of whiskey per day. He is also a chronic tobacco chewer since 15 years. On summary, a middle-aged chronic alcoholic and a chronic tobacco chewer who came with a complaints of pain abdomen since 6 years, aggravated since 3 months, associated with mass per abdomen and significant weight loss with loss of appetite and early satiety since 3 months, and passage of eye-colored urine and clay-colored stool since 2 months, yellowish discoloration, easy fatigability, and generalized weakness since 1 month. With this summary, I would like to think of an obstructive jaundice, maybe a pancreatic pathology due to chronic pancreatitis or maybe due to periampullary carcinoma.
Okay, should I start? Rashmi, a good history. Now, why do you think? Why do you take the history of sleep disturbance? What would be the causes of sleep disturbance in a patient of jaundice?
So now as it is associated with pain, sir, pain is disturbing his sleep, sir.
Any other cause which could be causing disturbance in sleep in a patient of jaundice?
Itching, sir, which is associated with severe itching, sir.
Itching. Anything else? Any encephalopathy?
Sir, cholangitis going for encephalopathic features and features of liver cell failure.
Could you just go back to your first slide? Yes.
Sir, I'm unable to share my screen, sir. Sir, I'm unable to share my screen, sir.
You'll have to wait for Dr. Kanagwal to come in.
Okay, sir.
He's still not on his screen.
Okay.
What is the difference
People
between
are
a
open. Can you share now?
Sir.
Not able to do?
Sir. Now I can, sir.
Yes, yes.
Rashmi, what is the difference between a referred pain, a radiating pain, and shifting pain?
Sir, in radiating pain, the pain at the initial site and the pain at the radiated site will be of the same intensity, sir. In referred pain, the pain at the original site will disappear and it persists at the site of the reference, sir.
In shifting
What's the
pain,
reasons for that?
Sorry, sir.
What is the
Shifting
reasons for
pain.
this?
Shifting pain, the pain will be at the same intensity even along the path, sir, from the original site and even at the shifted site.
Can you give the example of the shifting pain? Can you give any example of the shifting pain?
Sir, in gastric ulcer, sir, the pain in the epigastric region, even which radiates to the back, it can be even radiating type of pain or a shifting type of pain.
You
No,
should
the
not
classical
confuse.
example.
Both are
Give
not
the
same.
classical example. What happens in the appendicitis?
Sir, initially the pain will be in the around the umbilicus, sir. Then it will get shifted to the right iliac fossa, sir. At
That
the
is a shifting
mid-thigh
pain.
nerve.
So that is a shifting pain. No?
Sir.
Why
So
there is
why does
shifting
a
pain?
blood transfusion causes a jaundice?
Sir, along with the blood transfusion, the hepatitis B virus, which is the most common contaminant, which can be transfused.
What are the various times when it can cause a jaundice?
Sorry, sir.
Like today you have given the blood transfusion. What are the various timings when it can cause the jaundice?
Sir, if the blood transfusion has caused acute hemolytic reaction, sir, then you can
Yes.
see the evidence of jaundice within a short span of 1 week, sir.
Right.
If it is due to transfusion of a viral stuff due to hepatitis B or any other virus which is causing jaundice, sir, it may take around 2 to 3 months, sir.
Right.
Rashmi, in this case, you said initially the pain was penetrating nature, pricking in nature, and it is radiating. Then you said
Sir.
it is a colicky in nature. And how
Sir.
do you explain these two type of pain?
Sir, initially since 6 years, when the patient developed pain, it was mainly in the epigastric region, sir. That was pricking type, which was radiating, sir. Now, when he noticed the mass in the right hypochondriac region, that mass is associated with the pain, which is of colicky type, sir.
So what is the colic reason? Why that is colicky pain?
Probably as this patient is a chronic alcoholic, sir, it has caused pancreatitis, which is the most common acute and chronic pancreatitis, as he is developing
What do
pain
you,
since
what do you
6
mean
years.
by colicky pain? What do you mean by colicky pain? Why do we
A
get a colicky pain?
severe episodic pain due to luminal, sir. Luminal pathology will cause colicky pain,
So what
sir.
is the luminal pathology here?
Here, gallbladder and common bile duct, sir, in this case.
So pancreatitis producing a colic in the CBD.
Sir.
How?
Compressing chronic pancreatitis causing compression of the lower end of the CBD, causing reflux and biliary colic, sir.
This cannot produce only when there is an
Pancreatitis
obstruction
causing
to overcome.
spasm of the gastric muscle. So gastric aparesis can cause colicky pain.
Oh, kindly please go back and read your concept on the radiation and referred and shifting. And you are just saying the superficially the shifting pain is from that. Shifting pain, there is a pathogenesis is entirely different. Radiation pain is entirely different, and you must understand this pain properly and explain the words.
Okay, sir.
And this is not appropriate. Putting this doing is a pricking pain, then suddenly shifting into a colicky pain, and you are saying the same pathology is there, persistent, the same disease is there.
Okay.
So you said there is an yellowish discoloration of urine for 2 months and eye signs for 1 month. Why there is so much a difference between this eye signs and urine?
Sir, patient attender has noticed the yellowish discoloration of the eyes, sir.
What is the difference between hyperbilirubinemia and jaundice?
The jaundice is a clinical manifestation of increased bilirubin, sir.
Hyperbilirubinemia?
There is a increased in the bilirubin level in the jaundice without clinical manifestations, sir.
How much?
Sir, for clinical to manifest, it should be more than 2.5 gram per deciliter, sir.
Lakshmi, how could you reach to the diagnosis of chronic pancreatitis in this patient based only on the history? That even you will not make a diagnosis even after your full diagnosis. But based on the history, you are reaching to the diagnosis of chronic pancreatitis. You can simply say the patient have a patient just have the jaundice.
Okay.
Okay. Chronic pancreatitis comes 4th or 5th or 6th in the differential diagnosis.
Okay.
It never comes as the first diagnosis.
Okay.
Okay, can we go with
Rashmi, can you go back to your slides? Previous slide.
Sir. Which one, sir?
Still one more. Okay. Next. Okay, here you have mentioned that there is a history of yellow disc. Go back. Go back. Yes. No, forward one. See, I want to ask, you have mentioned that there is a history of yellow discoloration of eye and history of fever. So can you correlate?
Sir. Here the patient may be going to form a cholangitis, sir.
But in your now go back to the summary.
Sir.
Summary, yes. Summary, you have nowhere mentioned that there is a possibility of cholangitis. Why you are not thinking
because
in sense of
the fever which is seen in this case is not associated with chills and rigors, sir. So as it is mild degree, I am thinking of pancreatitis, inflammatory process which is causing fever in my case, sir.
Rashmi,
definition of
what
chronic
are the other
pancreatitis?
symptoms you would like to see?
Sorry, sir.
What are the
Definition of chronic pancreatitis?
Other symptoms?
You would like to see when you are talking about fever and pain?
Sir, intermittent fever, intermittent pain, and intermittent jaundice will go more in favor of cholangitis, sir.
Okay.
Rashmi, you've taken history of waxing and waning. You said no waxing and waning.
Sir.
How did you take the history of waxing and waning?
Sir, initially, patient will complain that he has an episode of jaundice for a short period, which has regressed completely. Then again, he will develop.
No, regress completely?
Partly, sir. The intensity will be reduced compared to previous. Okay. Then again, he starts developing the jaundice.
But so how did you ask him? You said, does the jaundice really come down?
Not completely, sir.
No, even, is it appreciable if the jaundice comes down, the bilirubin comes down from say 7 to 5? Is it appreciable on to a person? Especially when the relatives are telling that he has jaundice, he's not appreciated it himself.
Sir.
So what are the other ways of finding out whether there's waxing or waning?
The associated symptoms will also be relieved, sir. Associated pain and even the melena will be relieved for a short duration, sir. And again, the patient complains of similar.
Melena would be relieved.
Periambulary carcinoma is a painful
What is the cause? What is the cause of waxing and waning?
The sloughing off of the tumor which is present at the ampullary.
So when there's sloughing happening, there will be melena?
During sloughing, there will be melena, sir.
Yes. So how can then the jaundice, the patient will improve? Won't he?
Sir. Sir.
So he will feel better. His appetite will come back. He'll feel slightly better. That is how you take waxing and waning.
Commoner cause.
And why does this? Sorry. And why does this slough? Why does it slough?
Because of necrosis of the tumor.
Why does it get necrosis? At what size?
Sorry, sir?
At what size of the tumor will necrose?
So once it... Sorry,
when
sir?
does the tumor necrose? Why does it necrose?
Because of the ischemia of the center part of the tumor, sir, it will get necrosis.
So if the tumor is larger than 2 centimeters, there is usually necrosis.
Necrosis, sir. Center region.
Any other cause of waxing and waning?
Commoner.
The common CBD stones, sir.
Right. The stones are moving.
Sir.
So always say common cause first. Whenever you are describing any symptom, the common cause should be described first.
Okay.
Rashmi, I have to ask you a few questions. What is the age of your patient?
35 years, sir.
why didn't you consider CBD stone? Please answer my question.
Sir, in my case, as he is a chronic alcoholic and that pain was...
We come straight to the point. Alcoholic people also can have a CBD stone. Why didn't you consider CBD stone in a 35-year-old fellow who had a pain, who had a 6 years duration? Correct? Tell me now.
Your pain radiates to back, sir. 1 point.
I am asking you, why didn't you consider CBD stones?
I didn't.
As your just think.
The pain radiating to back is not only pancreatitis, the other causes also.
So there is a persistent progressive jaundice in my case, sir.
Patient had 6-year history of abdominal pain radiating to the back.
Sir.
Very fact that it is 6 year means it cannot be every day. It has to be intermittent. It is a common sense.
Sir.
Patient had fever. Just patient has fever doesn't mean he has got ascending cholangitis, or it can be a part of the infection. Patient would have gone to a doctor, he would have been treated. My question to you was, why didn't you consider? Because now you should tell patient has lost significant
weight, sir.
Weight
loss with loss of appetite, sir.
So now correlating these two with your diagnosis of chronic pancreatitis, as a first diagnosis, can you have put a better diagnosis?
Sir, severe weight loss with radiation pain and early loss of appetite will go more in favor of pancreatitis than CBD stones, sir.
No.
Can there be pancreatitis with CBD stones? Can there be pancreatitis with CBD stones?
Sir. Secondary CBD stones, sir.
CA head of pancreas is a disease of young age or old age?
Old age, sir.
Yeah. So why are you keeping this?
Rashmi, not to cause confusion, the question I asked you was, if you consider it is chronic pancreatitis, now significant weight loss, whatever you are talking, chronic pancreatitis is a pre-malignant condition. You could have put as a one diagnosis, sir, probably recently it would have gone for a malignancy. Finished. Why get into complications? One. Second is, if they ask you why patient had developed mass, what is your explanation for this mass, which you said patient felt? What is the mass which patient felt?
Gallbladder mass, sir. Gallbladder mass, sir. Gallbladder mass, sir.
Gallbladder mass.
Distended gallbladder.
Distended gallbladder.
You mean patient felt or you felt?
Patient only complaints on the right side, even diffuse hepatomegaly.
Let me tell you, so you are coming to the point. What you should have told is, if it is a benign condition like CBD stone, the mass can be hepatomegaly. Also can happen because of back pressure. If it is malignancy, the mass can be gallbladder, mass can be liver. You have to try to correlate rather than giving little confusion of the your analysis of the history is very important.
Okay.
Because 6 years duration is there and recent duration of loss of weight is there. Right? Number one. Number two, better use the word manual laborer rather than coolie. It doesn't sound a good thing. All right. Whenever you are presenting. And the itching part you are not highlighted in your summary. Summary.
Okay, sir.
Very important.
No itching, no?
No itching, sir. Not associated with itching, sir.
What prompted you to think of obstructive jaundice?
Sir, eye-colored urine, clay-colored stools, other features are promoting me towards the...
No, again, we have already discussed much time. Don't use the term clay color. Color of the clay is much different.
Pale stool, sir. Pale stool, sir.
So with that, you cannot make a diagnosis only obstructive jaundice. What prompted you to think? You are thinking in one time it's a chronic pancreatitis, and another time you are thinking it's obstructive jaundice. And what made you to think of obstructive jaundice?
As there is associated mass also, sir.
Now you are trying to say there is no mass, it is only the GB is distended.
Sir, I said both associated with mass.
There is a mass and separate GB.
Sir.
Look, Rashmi, actually...
So where is the mass? Mass is from where? Which mass you have? Where is the mass?
The mass, the mass is involving the upper right part of the abdomen, sir, involving epigastric, even the right hypochondriac region, sir.
What is that?
Hepatomegaly with GB mass, sir, it was.
No, no.
So
We are just talking
hepatomegaly,
about
no way it
history.
is an obstructive jaundice.
This is your examination finding up to by
Up to
your
history.
history only what it can be. This is what you would think. Summary of
What is
history. Forget your examination finding at present.
Okay,
At
sir.
present, we are discussing the summary and your presumption of diagnosis up to the history.
Sir.
Forget your examination finding.
Sir, as I'm thinking this case as chronic pancreatitis, which is causing obstructive jaundice, sir. So this mass could be either the enlarged liver, we associated a GB mass. If I'm thinking it as a CBD stone as the cause for my obstructive jaundice, sir, there wouldn't be the enlarged gallbladder, sir, or the dilated liver, sir.
So use word distended gallbladder rather than gallbladder mass. That itself
Okay,
is different. It means a difference.
Okay,
Different.
sir. Okay.
Rashmi, in your by history, you cannot come to make so many diagnoses. You'll have to give just a question of possibilities, right?
Okay, sir.
Because you've got a range of symptoms. You've got a mass, you've got a jaundice, you've got obstructive jaundice, you've got features of pancreatitis. You can't put all of them in one picture at present without examination. Okay? So don't say that it's malignancy straight away.
Okay, sir.
Because in a young man, 37, usually you see a
Benign
pancreatitis, right? And 6 years long, okay?
Sir. Okay.
Okay, Dr. Rashmi.
Sir.
Hello.
Sir.
I've got two questions for you. When you took this history of this bowel habits, what are the pertinent questions that you asked when you asked for the various bowel habits?
Sir, increased in frequency, sir, or altered bowel habits like frequency or consistency of the stool, sir, associated with the melena or the color of the stools or odor, sir.
What do you mean by diarrhea?
Sir, increased in the frequency when compared to daily routine, sir. Frequency or consistency of the stool compared to the daily patient routine.
Frequency and?
Consistency, sir.
Or in terms of the output?
Increased in the frequency and output and consistency. When compared to the previous normal habit of the patient, sir.
In general, if you have to quantify, when you talk of defining diarrhea, how will you define it in terms of quantifying the output and the frequency?
I think we are digressing. I think can
we go on the examination now? I think we had enough of the history now. Yeah. Go on the examination now. Yeah.
Oh, why can't she complete that answer?
Sorry, sir.
Can you complete that answer, or we go straight away to that? This question is to be discarded, is it?
No, sir. I'll tell, sir. Diarrhea, based on the frequency, it is mild degree, mild, moderate, and severe, sir. Diarrhea, low output diarrhea, high output diarrhea, sir.
Okay, we just wanted in terms of more than 200 grams per day and more than 3 times in a day. Okay. And how do you define significant weight loss?
If it is more than 10% for 6 months, sir, or more than 5% for 2 months, or more than 2% in 1 week, sir.
Whatever it is, if you quantify it as an unintentional weight loss, that is the most important part of the thing. Yes, now we move on to the examination. Yeah.
Yeah, go on the examination now. Yeah.
Coming to general physical examination. Here is a middle-aged male patient, moderately built and poorly nourished, conscious, cooperative, well-oriented time, place, and person. His Karnofsky performance scale is 80. Icterus noted, clubbing present, grade 2. Lymphadenopathy, there is a localized left supraclavicular lymph node present. I'll be explaining in my further examination. There is no evidence of pallor or pedal edema. There is no evidence of scratch marks. This is a deep yellowish discoloration noted in the sclera and even the undersurface of the tongue. Whitus patient is afebrile right now at the time of examination. Pulse rate is 92 beats per minute, good volume, regular, normal flow, with blood pressure of 100 by 70 millimeters of mercury, and respiratory rate is normal. Coming to per abdomen examination, patient examined in supine position with adequate exposure. On inspection, abdomen is flat, umbilicus is central, fullness noted in the right hypochondrium and epigastric region. A globular mass noted in the right hypochondrium, roughly measuring 7 × 5 centimeter, which is around 6 centimeter from the right costal margin in the mid-clavicular line.
Shift the slide quickly.
Moves with respiration. There are multiple primary yield burn scar marks noted in the epigastric and right hypochondriac region. All quadrants move equally with respiration. There is no dilated veins, no visible peristalsis, hernial orifices are intact, and external genitalia appears normal. On palpation, there is mild tenderness present in the right hypochondriac, epigastric, and right lumbar region. There is a diffusely enlarged mass which is palpable, 3-finger breadth from right costal margin extending in the epigastric, left hypochondriac, and right hypochondriac region, with smooth surface, round border, firm in consistency, which moves with respiration. Finger cannot be insinuated between the mass and the costal margin, which is suggestive of hepatomegaly. There is another tender 7 × 5 centimeter globular shaped mass, which is palpable in the right hypochondriac and right lumbar region, with well-defined medial, lateral, and inferior borders. Medial border is extending lateral to the lateral border of right rectus abdominis muscle, which is around 7 centimeter from the midline. Inferior border is 9 centimeter from the right costal margin. Superior border is continuous with the lower border of the liver. This mass has a smooth surface, firm in consistency, it moves with respiration. There is no other mass palpable in the abdomen. I have a short video where you can make out the mass which is moving clearly with the respiration. On percussion, the liver scan was noted to be around 16 centimeter. This mass was dull to percuss, and this dullness is continuous with the liver dullness. Shifting dullness is noted. On auscultation, bowel sound was present. On parietal examination, mucosa was normal, no nodules noted, and there are stools, clay-colored stools present over the gloved finger. On examination of the left supraclavicular fossa, there is fullness noted in the left supraclavicular fossa. On palpation, there are 2 lymph nodes are palpable in the left supraclavicular area, measuring 2 × 2 and 2 × 1 centimeter, mobile, non-tender, hard in consistency. On summarizing both my history and examination, a middle-aged male who is a chronic alcoholic, a chronic tobacco chewer, with chronic pain abdomen since 6 years, which is radiating to back, with associated mass per abdomen and significant weight loss, a loss of appetite and early satiety since 3 months, with eye-colored urine and clay-colored stool passage since 2 months, eyelash discoloration since 1 month, easy fatigability and weakness since 1 month, with palpable hepatomegaly and then palpable gallbladder, with left supraclavicular lymph node and ascites. By history and examination of my patient, I came with the diagnosis of obstructive jaundice due to carcinoma head of the pancreas with metastasis.
Only this diagnosis, or any you want to keep a differential diagnosis?
Obstructive jaundice, maybe it's periampullary carcinoma, sir.
Metastasis. Okay, why do you say it's obstructive jaundice?
Sorry, sir?
Why do you think it's obstructive jaundice?
As history-wise, there is an history of jaundice with the passage of eye-colored urine and clay-colored stools. On examination-wise, we have seen the hepatomegaly with the palpable enlarged gallbladder, which goes more in favor of obstructive jaundice.
And you have seen the supraclavicular node. Where do you have seen the supraclavicular node? What is the boundary of supraclavicular fossa?
Posteriorly by the anterior border of the trapezius muscle, sir. Anteriorly by the lateral border of the sternocleidomastoid muscle, sir. Inferiorly by the superior border of the clavicle, sir.
So its entire posterior triangle is supraclavicular node, fossa.
This is posterior triangle. So the area which is immediately above the clavicle is supraclavicular fossa.
No, there is a supraclavicular triangle. And there is a difference between what the supraclavicular node which we are seeing in a malignancy and the supraclavicular triangle. Where is the supraclavicular triangle?
Between the two ends of the sternocleidomastoid.
In the picture, what the node you are seeing is only in the posterior triangle.
Sir.
Do you think these are the significant supraclavicular node?
Yes, sir.
The supraclavicular node only when you are seeing between the two heads of the sternocleidomastoid is a significant node.
That is Trousseau's notes. What
So
is
Virchow note.
Virchow's note. So you have said metastasis. By showing a posterior triangle node, you can't show that it is a metastasis.
Sir, I have a doubt in this, sir.
Can I say something, sir? Sir.
Yes, sir.
You normally divide them into levels, no? As per that, it comes actually. It's under somewhere 4B.
4B.
So 4B. So they are about 5 to 6 supraclavicular nodes are there. Totally, if somebody asked the question, how many are there? Definitely not 10 or something like that. Maybe 5 or 6 are there. Usually grouped under 4B. The site is possible, sir. What she has shown, that site.
She has shown the posterior triangle, sir. Posterior triangle cannot be 4B.
That's right. I agree with Dr. Jaya. Actually, these are posterior triangle nodes. Your virtual nodes is at the two heads at the two heads of the sternocleidomastoid.
Sir, I have a doubt regarding this.
1 minute. In between the two heads of the sternomastoid were to be called as Kellene node. I am just talking about whatever has been, and they are typical of bronchogenic carcinoma. This, after it came as 4B, there is a slight confusion amongst us. Even in carcinoma of the breast, you get the nodes. They are also called as supraclavicular nodes. They are not in between the two heads of sternomastoid. Easily felt in carcinoma of the breast, posterior triangle. So, sir, it is accepted, sir.
Okay. No. If you are seeing, sir, only when you are seeing the node in the supraclavicular triangle, it comes under 3C, N3C. If it comes as a posterior triangle node, yes, you can get posterior triangle node. It comes as a metastasis. It will not be put as a N3C. N3C nodes has to be within the two heads of the sternocleidomastoid.
I am not talking about N3, that classification, sir. I just...
Okay, I think...
Yes, that's a different metastasis. You can go to any level.
Sir, can I clarify, sir? Sir, anywhere nodes in the supraclavicular fossa in relation to the abdominal complaint, it generally will think that it is an intra-abdominal malignancy, producing a metastasis. That's what I want to say.
Yes,
in between the two heads of sternocleidomastoid, there is a troisal sign, is more often seen in the carcinoma stomach, particularly. But any intra-abdominal malignancy can produce a metastasis in the supraclavicular fossa. They are also called as a lymph nodes in the supraclavicular fossa.
Okay,
lymph node, particularly we should address to the in between the two heads of the sternocleidomastoid. I hope I am a little clear.
Okay, right. Okay, Rashmi, what is Trousseau's sign? Did you look for anything on his leg?
No, sir. There is no feature suggestive of migratory thrombophlebitis, sir, which is characteristic.
You should have mentioned that if you are thinking of CF band.
Okay.
Okay,
now how will you proceed?
But no history of any abdominal symptoms. No, there is no vomiting. There is no epigastric pain.
There is epigastric pain, sir.
No, vomiting. Head of the pancreas will not cause GI tract symptoms. GI malignancy. You said it can go on to the extent of producing obstructive jaundice, but will the head of the pancreas, will it not cause symptoms related to GI tract?
Usually it will present, sir. Present with the symptoms of even GI tract.
Why does it present?
Pyloric spasm, sir. Because of pyloric spasm, sir.
It presses onto the duodenum. It's in the C of the duodenum, isn't it?
Sir.
So that's why.
Compressing on the medial part.
Rashmi, 1 or 2 questions. Hepatomegaly, you think is secondaries in the liver?
No, sir. In this case, no, sir.
Why not?
Because on examination, the surface is smooth, sir. Margin is border or soft, sir. Firm in consistency,
How big is the liver? How big is the liver?
Sir, 3 finger breadths from the right costal margin.
From
sir.
which end to which end?
So extending even from the left hypochondrium till the right border.
And patient has no itching?
No, sir. You don't have any itching at all, sir.
So that means to say such a grossly enlarged liver, patient has no itching, and you say there is no secondaries in the liver, and patient has supraclavicular nodes.
Sir.
I just want your thinking capacity. That's the only reason I'm asking. Not that in medicine anything can happen. Patient has ascites.
Sorry, sir?
Does your patient has ascites?
Yes, sir. Patient has ascites is present in this case, sir.
I am asking you a question. Why not? It is carcinoma, gallbladder with metastasis in the liver and supraclavicular nodes with ascites. Which one is more rapidly growing tumor in this? gallbladder carcinoma or head of the pancreas?
Sir, gallbladder carcinoma is growing, sir, but in the for this age group of gallbladder malignancy, sir, and
Tell me.
gallbladder carcinoma is rapidly, but
No, don't bring the age now. Now talk only on your clinical findings of the gallbladder which you have felt. Why not carcinoma gallbladder? That is my question.
the gallbladder is in my patient, and even there is no feature suggestive of metastasis even in the liver also, sir. Gallbladder is diffusely enlarged with smooth surface, sir, and firm in consistency, sir. And even the liver which is enlarged is not suggestive of any features of malignant metastatic spread like nodular surface or sharp border, sir.
How the features are different if you think of carcinoma of the gallbladder? That's what Shani sir wants to know that.
The gallbladder will be hard, sir, hard in consistency, sir.
Irregular surface.
Irregular
Depending
surface,
upon the
hard in
location.
consistency.
Okay, it will depend on the location where the gallbladder carcinoma is. That is why you have to always keep a differential diagnosis of the carcinoma gallbladder in our circumstances. There is no doubt about that. Okay.
Okay.
Because if the carcinoma arising from the neck of the gallbladder is there, it will produce a similar type of the lump.
Okay.
You know what is this called a hepatomegaly, which is there without any metastasis? What is that called as?
Hydrohepatosis, sir.
It is called a hydrohepatosis.
Hydrohepatosis.
That is because the back pressure which is there, so the patient may have a big. And you
Sir.
always mention about the hepatomegaly where you have felt. You said 16 centimeter. Okay, hepatomegaly will be different. Yeah, always say in the mid-clavicular line.
Okay, sir.
Okay, because on the right side it will be much bigger as compared to the left side. So you have to always tell that mid-clavicular line, the liver span is this one. Okay, always tell about that. Yeah.
Okay, sir.
Okay, go ahead.
Just a small spelling correction. Blummer, B should be capital, okay? Blummer self. Please don't do mistakes. Yeah.
Okay, sir.
Okay, now how will you
think
proceed?
there is an ascites? You said there is an ascites.
Sir.
And in this connection, what is the reason for that ascites here?
It could be because of metastasis, sir, in my case.
Metastasis where?
Sorry, sir?
Where
Omental-
metastasis?
Peritoneal omental metastatic deposits are causing ascites, sir.
So the patient has an extent of peritoneal metastasis, but liver is spared.
Sorry, sir?
You said there is a metastasis in the supraclavicular node, there is a metastasis in the omentum, but the liver is spared. There is no secondaries in the liver.
Sir. Clinically, there is no feature suggestive.
So,
of
Rashmi,
metastatic.
what would be the causes of ascites in a case of obstructive jaundice?
Sir, it could be because of hypoalbuminemia, sir. Hypoproteinemia and hypoalbuminemia is the first cause. Then because of metastasis also, sir.
And any other cause?
Metastasis.
Okay, Mets, peritoneal Mets. Any other cause?
Why not? It's a chronic alcoholic, just a cirrhosis liver producing an ascites.
In cirrhosis, usually liver will not be palpable, sir. Cirrhotic liver.
Alcoholic liver will be palpable. It is a macronodular cirrhosis.
Okay.
Right. Even if lymph nodes are pressing onto the portal vein, portal system, it can still cause ascites. Okay. So these are the three causes.
Adding on to, because the discussion in your case is going because age is not in favor of malignancy, as everybody is telling. We are talking about chronic pancreatitis turning into head of the pancreas with the ascites, with the everything, but liver is according to is normal. So I will ask you a third differential diagnosis. Why not a large hepatoma? Just answer question only for differential diagnosis. Alcoholic, as Dr. Jayalal said, he is an alcoholic fellow and he had a big nodule. Now he has developed hepatoma recently.
Sir, history-wise, there is a jaundice, sir, which will not go in favor of hepatoma. On examination-wise, liver is uniformly enlarged, sir. Liver is uniformly
jaundice.
Do you expect a distended gallbladder in hepatoma?
So you should answer like that. So what you should tell is, it is possible. See, you have brought the third diagnosis is carcinoma of the stomach. Why did you think of carcinoma stomach? Somebody was asking, no vomiting, nothing is there. So you should have which hepatocellular carcinoma, I agree, but he is an alcoholic fellow, cirrhotic fellow, liver function is deranged, and you said no itching in your patient. So what you should tell is patient has palpable gallbladder. So this is how you try to come out of your answers in the examination. A case, this is not a straightforward case in the form of, history-wise and interpretation of findings.
Sir.
So one moment, let me check. Jatin Das sir and Dr. Siddharth Dubashi, do you have challenges, sir? I would say please unmute yourself and ask questions, sir. I think you people have the priority for the day. Sorry if I could not arrange for a proper communication. Are you okay, sir? Both of you? Jatin Das sir, I could not. I could see him inside and I think his video is not with us.
I'm with you.
Siddharth sir, thank you. Jatin Das sir, are you with us?
Kandan also not visible. Kandan has joined?
Sir, I think today also, I think there is a challenge. Like the latest version Zoom, whoever has not updated, they could not join, sir. That's what is my feeling. Many people last week also we had challenge. Even Vivek, I told him to re-upload themselves. Jatin sir came into the class. Jatin sir, are you with us? Siddharth sir and others, please take over. Let me check with the other.
Yes, you can proceed with the investigations if the examination questions are over.
Okay.
You proceed with the investigations, Rashmi.
Sir. Sir, usually I would like to get hematological investigations first, sir. Complete blood count, liver function test, PTINR, then RBC, ultrasonography initially to evaluate, sir. Sir, I'm not in.
So you must be a little more specific when you are writing the notes. You cannot just write CECT. You must write specific.
Pancreatic protocol, sir. Contrast general CT with pancreatic protocol, sir.
So that's where you must always write. Is there any role of ERCP?
Sorry, sir.
What is the role of ERCP?
Any role of ERCP? You are not mentioned ERCP.
Sir, in this case, sir, in my case, as it is a case of metastasis, I would like to do ERCP, sir, for palliative process like stunting and all.
No, you are not put the ERCP in your list.
Okay.
There is no ERCP is there. It's only EGD is there.
Sir.
Okay, Rashmi, you would like to do a liver function test.
Sir.
What is the test for bilirubin? What is the test called?
Vandenberg test, sir.
Vandenberg test. What does Vandenberg test tell you?
Sorry, sir.
What does Vandenberg test tell you?
Whether it is a direct bilirubin or indirect, the conjugated or unconjugated bilirubin which is elevated.
Okay. And what about ultrasound? What do you expect from an ultrasound? What do you look for?
Initially, I would like to look extrahepatic biliary system status, sir. Status of the CBD, whether dilated or the causes of dilatation, whether due to stones or strictures or a growth. Then gallbladder status, then biliary radical status. Then I would like to look on pancreas, sir. Pancreas, if I can make out whether there is an associated mass or fetal suggestion of chronic pancreatitis.
Anything else?
Ascites, presence of ascites, sir, and presence of any other features.
If you're thinking in terms of chronic pancreatitis, second going for malignancy, what are you suspecting? What are you expecting in ultrasound?
Chronic edema, sir. Chronic pancreatic edema.
Other than that, ultrasound can brilliantly pick it up.
Fibrotic parenchyma with the multiple dilated either duct or
What else? What else?
Sorry, sir.
What else? Chronic pancreatitis. Multiple calcific foci could be seen even in the throughout the pancreas and the head regions.
Okay. Any other blood tests would you like to do?
Sir, PTINR I've taken to know for the liver function.
No. Other than this, what you've
listed. Diagnostic.
CA99 level or CA level, sir.
What about amylase? What about amylase?
Rashmi, you are given a choice of one investigation in the LFT to differentiate between whether it is a surgical jaundice or whether it is a medical jaundice. What one investigation you will do to differentiate on the LFT?
Alkaline phosphatase and GGT, sir.
Gamma GT, no?
Sir, gamma GT.
That you are not mentioned here in your list. Probably that is the most important investigation to differentiate between a.
Sir.
Okay, you've done this. Now, what else will you do? You've done your. What will you look for in CA 99 and CEA? How much should the level be?
The CA 19.9 is more specific compared to CEA, sir. More than raise in more than 100 level. 100 is suggestive, sir. 1000 is specific for malignancy, sir.
Okay. Okay. So you've done this. Now, what else will you do? You've done an ultrasound. What then you do? You've done an ultrasound. Anything else?
According to the report here, sir, liver function is normal, sir. It is not deranged, sir. So then after ultrasonography,
Liver function, you've got your bilirubin is 6.6.
Sir, functioning of the liver, like the albumin synthetic is normal, sir. But on total bilirubin and direct bilirubin is instead, which suggests of more of obstructive, mainly because of malignant etiology, neoplastic etiology, not it is true.
Okay. So what else will you do now? You've done your ultrasound. You've done your CT abdomen. What else will you do now in this patient?
If endoscopic ultrasound, sir.
Why do you want to do an endoscopic ultrasound?
As this is a case of a clinical and examination wise, it is a case of metastasis, sir. For diagnostic purpose, I can take FNAC, but for in this case, as there is already supraclavicular lymph node present, I can take FNAC from supraclavicular.
No, you said you'll do an endoscopic ultrasound. Why? I said why. Now you're saying because there's a lymph node, I'll not do it. You tell me why will you do it? Any reason for doing an endoscopic ultrasound?
Rashmi, when you consider it is a metastatic disease, does endoscopic ultrasound is going to help you in some other way?
To confirm the diagnosis, sir.
No, you can go to percutaneous also because it's advanced disease.
But seedling will be more in doing percutaneous, but the seedling will be less in US.
What is the most important function of US?
Sir, it can be used as diagnostic and even therapeutic also, sir. This US guided stenting can be done, sir.
Okay, what are the indications for taking a biopsy in a case of obstruction?
Sorry, sir?
What are the indications of taking a biopsy in a case of obstructive jaundice?
When do you really need a biopsy when you're suspecting obstructive jaundice?
Sir, whenever the tumors you are suspecting are borderline resectable, sir, to confirm the diagnosis, to take the biopsy, I'll do endoscopic ultrasound.
Borderline malignancy.
Endoscope ultrasound will be also telling you about arterial encashment, if there is an encashment which is happening there. So that will always also tell you about the possibility of resectability or not. So when there is
only two indications. There are only two indications for taking a biopsy.
Sir.
Does US is going to help you in any way apart from taking up the biopsy and look for the encasement of the vessels? Does it be very useful for any other purposes in this particular case also?
In this case, what are
therapeutic?
What is that? What therapeutic?
Palliative purpose, sir.
What exactly? I want the answer.
Stenting, sir.
No, stenting it doesn't require US. Stenting doesn't require US. How to relieve the pain? How to relieve the pain in this patient?
Biliary stenting, sir. Biliary stenting and
pain. How we are going to relieve the pain?
Celiac block, sir. US guided celiac plexus block can be given even with the US, sir.
The best way is to do celiac plexus block is a US guide. It is more precise nowadays.
Okay, Rashmi, the two indications for doing a biopsy: one is when you're going to go in for neoadjuvant chemotherapy, and two when you're going to go for palliation.
Confirm.
These are the only two indications. Otherwise, you don't need a biopsy. Any other way of taking a biopsy? You said endoscopic. You said percutaneous. Any other way, better way of taking a biopsy?
Transduodenal, sir.
Laparoscopy.
Transduodenal.
No.
Right. Okay.
You can go in for a laparoscopy.
Okay.
Right.
You said supraclavicular node. Can you trace how the lesion secondaries reaches the supraclavicular node?
So the lymphatic surrounding the pancreas via the thoracic duct, sir, it reaches to the left supraclavicular region where it drains at the junction of the internal jugular vein and the subclavian vein.
So that's fine. It is drained into the supraclavicular vein. And why it is coming to the supraclavicular node?
Peripancreatic lymphatic, sir, which drains mainly into the
I fully agree, ma. You have reached up to the drainage at the junction. And from there, how it comes to why it comes to the node? You have said it is draining into the vena cava vein.
Because of blockage of the lymphatic by the tumor emboli, which cause spillage of the tumor cells, causes the presence of left supraclavicular lymph nodes.
So there's backflow actually.
Backflow.
Retrograde flow.
Retrograde.
Okay, so in this patient now, what will you do? You have confirmed this obstructive jaundice, right?
Sir. So now
you do a biopsy.
The CT in this patient?
Sir. This is a plain CT and this is the...
Okay, what is this pancreatic protocol, CECT pancreatic protocol?
In the CECT pancreatic protocol, mainly the images is taken at the axial thickness of 1 to 3 mm, sir, with a negative oral contrast to differentiate between the duodenum and the pancreas. It is ideally taken mainly the pre-contrast one, and then arterial phase, pancreatic parenchymal phase, and the portal venous phase, sir. Initially, pre-contrast film should be taken from diaphragm to the third part of the duodenum. Then after injection of the contrast around for 30 seconds, then arterial phase is taken within 20 seconds, and then pancreatic parenchymal phase is taken around 40 seconds. Then portal venous phase is taken around 70 seconds. Sir.
So why is it so important to take these phases in pancreas?
In arterial phases, the hypervascular tumor and other neuroendocrine tumors can be well made out in the arterial phase. Whereas in pancreatic parenchymal phase, the hypodense tumor and the hypodense lesion within the pancreatic pathology can be well made out. Sir. In portal venous phase, the venous encasement and other pathology can be well made out.
So well prepared. Good. Good.
No. 1 minute. I want to come in here.
Sir.
What is the importance of late arterial phase in a pancreatic protocol?
Late arterial phase. Rashmi, can you understand? Late arterial phase.
Parenchymal phase. What is the importance of that so-called parenchymal phase?
The lesion which has appeared hypodense in the initial pancreatic parenchymal phase will become hyperdense in the late phase. Which are just.
What do you mean by that?
The necrotic area which was hypodense and
there is no necrosis. There is no. We are dealing with pancreatic.
Malignancy.
The hypodense.
No, now you will start beating around the bush. I know. The answer is differentiation between the enhancement in the late arterial phase between the tumor and the pancreatic parenchyma is highest, and that is why the importance of parenchymal or the late arterial phase. That's the answer.
Okay.
Good.
Okay.
Thank you.
We've done a CECT. Now, what is the next step?
So in this case, I'll go for palliative management, sir.
What kind of palliation will you think of? What would be a palliative management? Any role of neoadjuvant chemotherapy?
Sir?
Any role of
neoadjuvant chemotherapy? Initially, complaining of severe pain, sir, I would manage the pain, sir. Then I'll neoadjuvant chemotherapy.
So what are the causes of pain in this patient now?
Sorry, sir?
What are the causes of pain in this patient?
Sorry?
What are the causes of pain in this patient?
The pain in this case mainly is due to nerve infiltration, sir.
Any other causes?
Due to pancreatic ductal dilatation, stasis, and then infiltration to the surrounding structure is the main cause in my patient.
Can there be pain because of hepatic distension, Gleason's capsule?
Sir? The distension will cause the pain, sir.
Can there be pain of ascending infection, cholangitis? Stasis of bile?
Yes, sir, there is not associated with fever, sir. It is not suggestive for answer.
You said there was a history of fever.
Not pills and rigors, sir.
Okay. So you'll give for pain. What else will you do now? You'll palliate his pain. What else will you do?
Celiac plexus blocks. I would like to give.
Okay, done.
I'll start up with NSAID, sir.
Okay, done. Pain is gone. Anything else now? What other palliation will you do?
He has come with pain of abdomen, and then he may have intermittent vomiting also. Would you like to do palliation?
So now I would like to pass for biliaries and gastric, sir. As this patient is complaining of pain abdomen, I'll go for gastric palliation either endoscopically or open, sir. Endoscopically, I would like to do duodenal stenting for gastric intestinal disease and biliary stenting to relieve biliary obstruction, as this patient has distended gallbladder with intrahepatic dilated biliary radicals.
No, hang on. You'll do duodenal stenting?
Pylorus stenting.
Pylorus stenting? Why do you
Sir,
want to do
because the medial part of the duodenum will be compressed because of the mass and infiltrated.
So a stenting would any other be simpler way?
No signs of vomiting, no signs of any GA symptoms. Why do you think there is a duodenum is obstructed here?
Because there is 15 to 30% chances of CA pancreas going for duodenal obstruction in future days, sir. So I would like to do it as palliative purpose.
Rashmi, you should talk about your patient, number one. Okay? Don't talk about 15 to 20% now. As
Sir,
rightly
in
put it, not even one day patient had vomiting. So don't think about stenting. You understand? Later you refer. If your patient survives, your patient has ascites and supraclavicular nodes. What is his survival? What is the median age of survival in your patient?
6 months.
Keeping that in mind, there is no role. Okay? Keeping that in mind.
Sir, in USG, it is showing thickening of the medial wall of the second part of the lumen with narrowing, sir. So
don't talk about that now. You are going to do a biliary stenting to relieve the obstruction, not pylorus.
So probably there too in the open vera, when you want to do open bypass in the cholecystogenostomy, hepatic jejunostomy, generally we don't want the patient to come back again with the obstruction. That many times we'll do prophylactic gastrojejunostomy, thinking that they're going for obstruction. In that context, probably right. When you're doing an endoscopic stenting, probably it is not required. Stenting.
Any role of multidisciplinary team, MDT? Any role of MDT in this?
No idea.
Abhay sir, yes.
See, Rashmi, this is all PGs. When you pick a patient who is not operable, and when I say not operable means intention to cure. My teachers always taught me one thing. If you hit such a patient, you have to know what is to be palliated. In your patient, your palliation will be jaundice and palliation will be pain. That's all. Because sonography is showing you something, prophylactically doing something is of no use. So please be very careful in answering such questions. So if I have to answer this question, I will be very clear. Number one, palliation of jaundice, palliation of pain. That's all. Right now, the patient is not obstructed clinically, sir. I will not do anything for this patient. As Dr. Osmani correctly said, when possibly we appeared for examination, there was no endoscopy, and we would operate on such patients and prophylactically do gastrojejunostomy as a bypass. In today's time, that's not an answer which is going to be accepted, especially in a patient with ascites and with a supraclavicular node positive. You understand? Stick to your patient, answer briefly, get out. All the best. You're doing well. Go ahead.
Second thing I would like to add, Rashmi, whenever you are asked, why do you want to do duodenal stenting when there is no vomiting, think what sir is asking, whether he is writing to prove asking you to prove what you said is right, or he is asking you to modify what you are saying. So just give a pause, give a thought, and then answer. If he is giving you hint that there is no vomiting, no GA symptom, metastatic disease, that means it is not required. Right?
Rashmi, why do you want to palliate the jaundice? Why you want to palliate the jaundice?
This chronic stasis, this biliary can go for sepsis, sir. So I need to prevent the obstructions.
Which is early. Sepsis is early.
No, I just want to ask one. If you have to answer so many things.
Cholangitis, sir. Cholangitis.
No, not the cholangitis. What is the most distressing feature for the patient with a jaundice, a surgical jaundice?
Usually.
The most distressing feature, which is really changing the lifestyle of the patient.
Itching,
yes.
But your patient has no itching.
I don't.
Yeah, this patient doesn't have the itching, but you know, as such, that is the most important thing. The itching, the lifestyle changing problem, which is there.
Are they go for encephalopathy if it is increased beyond certain limit? Rashmi? Can they go for encephalopathy if not sepsis? Itching is also there. Can they go for encephalopathy if the increased bilirubin is raised progressively?
Cholangitis with severe sepsis can be.
The cholangitis aggravates the encephalopathy. Even if there is no cholangitis, increased bilirubin can push the patient into encephalopathy. For that also you need to decompress the biliary.
Okay, Rashmi, how much can the bilirubin rise? What's the maximum bilirubin rise and why?
Sir, in malignant obstruction, it can go up to more than 30, sir.
No, tell what
Can
is
it
the
go to
maximum
40?
limit of
Can
that?
it go to 40? Can it go to 40?
Sir, up to 40, sir.
Can it go to 50?
50.
No, sir.
Why?
The maximum.
Why is 30 the maximum or 40 the maximum?
Reshmi, I think if you don't know the answer, it is
no.
prudent to tell I
Yes.
don't know at the beginning. Right?
Right.
All of you are at least experience of twice of your age here, right? So you should respect the seniority. If you know the answer, yes, should answer. If you don't know, you
Don't
just
guess.
upfront bow yourself and tell don't know, because they are here to teach you. This is not for you to try and test the examiners, right? Be honest and tell you don't know and don't know. Abhay sir.
Okay, I will give you the answer. The normal pressure in the biliary tree is 15 centimeters of water. Biliary secretion stops when the pressure reaches 30 centimeters of water, right? And this is around 24, 25. It can go to much beyond, but this is usually the average.
By the time your hepatocyte stops functioning, I think probably they'll go for.
I will give another explanation for that. You know, the maximum bilirubin can reach up to 45 mg%. And why it doesn't go beyond 45 mg%? Because after that, because of that hydrostatic pressure which is there, it starts exfoliating the bilirubin from the proximal jejunum. And that is why it happens that many times the patients who have got the pale color stools, now it becomes the yellow color stools because of this reason, that now the bilirubin is being secreted from the jejunum. So that is the reason it cannot go beyond the 45 mg%.
Rashmi,
Sir.
the whole discussion that has taken place, again for all PGs who are attending,
Okay, sir.
the question was very simple.
Sir.
What will happen if you don't treat this patient? That was the question. The bilirubin will keep on rising, one, and complications of stasis. This is the second thing. You kept on harping on the complications first, and that's why all the questions went on to 20, 30, 40, 45, etc., etc. So you should have straight away said increasing jaundice and complications of jaundice without sepsis, and jaundice with sepsis and death. These are the two things that answers that were expected, that are according to me out of whatever question you asked.
Okay.
The answers were simple. You made it complicated. And then Dr. Sahai obviously jumped on the opportunity to say 30, 40, 50. Don't allow them.
Okay, sir.
Okay.
You are siding with the students, sir.
No, my intention is to teach.
No, sir, I'm not. I'm trying to tell that what is the right approach to handle the examiners apart from the subject. What is the exam?
It is right approach to thinking. When I am asking, the mindset of the student is usually, is this a catch question?
Okay.
And once you get into that mode that this is likely to be a catch question, you start going haywire. She's doing very well, and suddenly little bit of twist, and she's starting to doubt the examiner. And once that starts coming in, the problem starts.
Okay, Rashmi.
I think we have another 5 to 7 minutes.
Right, Rashmi. What is acholuric jaundice? Let's come to basics now. What is acholuric jaundice?
A condition where normally, sir, in the case of jaundice, urobilinogen will be excreted in the urine, sir, which is one of the features suggestive of obstructive jaundice. In acholuric jaundice, the urobilinogen will not be excreted in the urine, sir.
So will the urine be dark, red, yellow in color or not?
Acholuric
What will be the color of urine?
Not be there.
Normally, the urine will not be yellow, sir. Eye color, not eye color, sir, not eye color.
No, the urine will be normal color.
Normal color.
Because some
absence of urobilin.
No, this is because
of urobilinogen or bilirubin?
Bilirubin. This is not urobilinogen. Urobilinogen is being
urobilinogen is still positive, still present.
It is bilirubin. Okay.
Dr. Hitesh just now has written that he has seen a patient with a 50 milligram.
Yes,
in fact, I have seen a patient with a 72 milligram also.
Okay.
But yeah, I've seen a patient with a 72 milligram also, but I don't know how it was there. Yes. But that is the maximum limit which is there.
Yes, so actually, the
literature
physiology
shows up to 80 milligrams, sir. That is the literature report.
Again, depends on the speed at which the duct gets compressed. Maybe.
Right.
The physiology basically says that the bilirubin
Yeah,
secretion
that's
stops after a certain pressure.
I think as the seniority becomes, it may be increasing. That's
So
Any other reason you want to bring down the bilirubin? What are the other complications you are
Of
expecting?
bilirubin, high bilirubin.
High bilirubin.
Rashmi, this is for you.
Okay. Patient may go for renal complications also, sir, because of increased bilirubin, renal failure, sir.
How will you prevent?
Diuretics can be given, sir. First, excess water intake, sir, adequate hydration, sir. Then we should give diuretics or mannitol, sir. Mainly preferably mannitol.
No, please again go and read. There is mannitol is contraindicated. The use of mannitol is not going to help the patients who is with a hepatorenal syndrome is going to develop. So either it could be an infection which has to be controlled, or you have to do a lot of other medicines which even you can do the heparin, you can do the other medicines to support the liver function, renal function, not the mannitol.
Look, Rashmi, in this patient, you have to manage infection, you have to manage jaundice, you have to manage pain, you have to manage his liver function. So you'll have to, it's a multi-pronged. It is just not that I will do. You have to think what you are going to do and go and say accordingly, okay?
Okay.
So hydrate the patient, give antibiotic, vitamin K, FFP if necessary, all that kind of things, right? PTC, stenting, everything.
Okay.
What are the two most important causes of hepatorenal shutdown?
Deposition of bilirubin or bile salts at the glomeruli, sir, which are unable to filtrate to the proximal convoluted tubules, sir, causing hepatorenal syndrome, going for acute kidney injury and renal failure, sir.
The two most important causes of the hepatorenal shutdown, one is the sepsis.
Sepsis.
And sepsis comes from the gut.
Okay.
And second is the hypotension. If you can avoid these two things in any case of the patient with a jaundice, probably the outcome will be better.
Okay.
So there are so many causes are there, but these are two most important causes: the sepsis and sepsis, the gut sepsis, which is there,
Okay,
and second is the hypotension.
Thank you, sir. I think now I will request the invited faculty for the day, Dr. Siddharth and Dr. Ishwar. I think Jatin sir is on the group, but his video is not coming. Can I request Siddharth sir to sum up, and should you need to ask question, can you please sum up and close the session, sir? Siddharth sir, please.
So it was a good discussion. Only thing is that we could not cover little bit points on the examination, but by and large we moved on. She did give a conclusion at the end of the history. That was a good attempt, and the examination findings were presented well. Though we did not have a lot of questions on examination, but then the overall approach, she did quite well. And I'm sure my senior colleagues will also agree with the same. So I congratulate Dr. Rashmi.
You would like to ask something to the candidate?
No, not at the moment, because since the discussion is over, we'll move on to the next case.
Ishwar Hosmani, sir.
No. People have to assess. I'm the internal examiner. I will not.
Okay. Dr. Jatin, please.
I asked other senior colleagues to.
Dr. Jatin, please. I think he's still not with us. I think Dr. Kannan is trying to join. Kannan, sir, are you with us? Okay, I think we have Professor Sanjay Jain with us. May I request Dr. Shanai sir or Ajay sir to close down. Then we move on to the next case, sir. Shanai sir, Abhay sir, please first. You raise your fingers first.
As usual, I have some very simple questions for her.
Please, sir.
Yeah, most difficult, sir.
She talked and accused the patient of being chronic alcoholic. So what is the definition of chronic alcoholism? Oh, sorry, chronic alcoholic.
Rashmi, can you hear? What is the definition of chronic alcoholic?
When will you give the title, alcoholic?
I think you should give the answer.
If it is a female, 160 ml peg per day continuously for 7 days is enough to call a person chronic alcoholic. There is no years that is mentioned. And for a male, it is 2 pegs a day for minimum of 7 days. years not mentioned is equal to a chronic alcoholic. I want her to answer
No,
this.
sir, but the definition of chronic alcohol is according to Alcoholics Anonymous is only when you have a physical dependence.
No, sir. No, sir. That's my second question. That is my second question. The difference between chronic alcoholic and alcoholism. Alcoholism is dependence.
Dependence.
When you don't have it, then you crave for it and you have neural disturbances. That is the time when you call a person alcoholism. She is hidden herself. I don't know. Moment I started.
No, it is unmuted, sir. Unmuted. It's not.
Are you with us, Reshmi? I think few are the challenges are there. Shanai sir, I think you please tell your words.
Ask her to be in the video.
Now, I wanted to give her a little more than 70% marks. So my question to her was, is she hearing me?
Yes, sir, she is with us.
Okay. My second question to you is, if you send this patient for ERCP and the patient comes back saying that ERCP is unsuccessful.
Reshmi, I would say remove your headset and listen to the system laptop microphone and speakers.
Okay, sir.
Are you hearing us?
Hello, sir.
Are you hearing me? Are you hearing me?
I think allow her sometimes, sir.
Sir, host has muted it. You please check whether she has been muted.
No, it is
no,
unmuted.
Sir. No. I don't mute.
Can you hear me now?
Reshmi, are you okay? I think you are now heard well.
Take your time. Because this is, can you hear me now?
Yes, sir.
Okay. If you want to get more marks from me, you're already through.
Obviously, you'll get it, sir.
To answer this question, you send the patient for ERCP and stenting. The patient is sent back saying that not possible, bad diverticulum present. Now what? Now remember, this patient has ascites too.
Failed ERCP, what you would like?
I'll do percutaneous transhepatic angiography.
Patient has ascites. Contraindication to PTC. There are only two options in front of you. Number one is send to a better center equipped for ERCP and drainage. Number two is to tap the ascites and try in that window period to do a PTC with added risk. And third, possibly to even higher centers, very, very high-end centers where they can do a EUS guided choledochoduodenostomy.
Abhay sir, can I add with the permission?
Yes.
Before going to the choledochoduodenostomy, you can do a anti-grade guide wire passage with EUS also. Right? Sir's technique is in one go, you complete the palliation with the LAMS. LAMS is very short stent and it gives the compression between the two ends, so no leak happens, especially in this patient with ascites. But a simpler LAMI stent is in fact devised by an Indian gastroenterologist, Professor Nagi Reddy. Of course, other Korean things are also there. They occludes the two lumen very nicely. But a simpler solution will be to use EUS for passing the guide wire through one of the dilated radicals, only receive the guide wire into the duodenum and you do a conventional ERCP. This is one way. But sir's technique is in one go, cannulation and palliation is happening in one go. And then the only challenge will be you should be using an occlusion stent. Am I right, Abhay sir? Anything?
Absolutely. This is for exam. I don't think routinely these questions will be asked, but if you do well, obviously these sort of questions are going to ask.
Sir, I have a question for that.
One from you is, how will you treat itching in this patient if it was there?
Sir, decreasing bilirubin will relieving the obstruction due to jaundice will cause, sir. Medically, I would like to treat with cholestyramine, sir. Medically treat with cholestyramine, sir.
Rashmi, see, my answer is, question is very, very simple. Again, don't make things complicated. Patient has come to you with obstructive jaundice and severe itching. Moment you go near him, he is scratching here and there. How will you treat this itching or at least lessen the symptom of itching?
Cholestyramine, sir.
Think
Cholestyramine with
something beyond. You have told that answer. The examiners are not convinced with their answer. Think beyond cholestyramine.
What do you apply
Some acids can be
face
used
every day when it is dry?
calamine lotion, sir.
Calamine lotion you apply to face?
So for itching, sir. I mean for itching, sir.
See, otherwise, if I show you Nivea cream, you'll start laughing. Simple emollient ointments are more than enough to decrease. This is what happens. Question is simple. You start making complicated. Okay. The more you answer correctly, the more you go higher and higher. That's why I put this question as the last question. Before that, I had put in a difficult question.
Okay.
Okay. So you got to be geared for ups and downs in examination. All the best to you.
Thank you, sir.
Yeah.
Ajay, you would like to add something, sir? Can we close this case and move on to the next case, sir?
Yes, sir, sure.
Rashmi, you did well. In fact, I take the privilege to offer you the chance to ask any questions to the examiners. Now we have a panel of national repute examiners before you. So do you like to ask something to the examiners to get clarified?
No, sir. Thank you, sir.
Thank you, Rashmi. Thank you. Credits to your department chief and your department HOD. Andariya, sir, please.
Sir, I have a question for Abhay sir and all senior faculties. If the patient is not ready to go for any hi-fi drainage procedures and we are in the periphery, is it okay to do ultrasound guided cholecystostomy in this patient or not?
Sir, ultrasound guided?
Cholecystostomy. Cholecystostomy.
It should work, sir.
For drainage of the biliary system. Right, sir.
I fully agree with you. Yes. I'm sorry, I was just eating a little bit. I fully agree with you. I would, rather than ultrasound guided, such a large gallbladder, I will possibly do a cholecystostomy under local anesthesia.
Yes, sir. Thank you, sir.
Sir, there are certain questions like this. What probably we can do to Indian scenario type of our patients. Sir. Right, it is something like telling inoperable carcinoma lower and esophagus patient doesn't want to go to anybody. Telling feeding jejunostomy, right. Probably not for postgraduates in the examinations. That's what I can see.
Hello.
Thank you, sir.
In fact, sir, the one other point which is suggested when you do a cholecystostomy, the amount of functioning of cholecystostomy, the durability of the treatment is much lesser when compared to PTC, sir. That is the one important thing. The number 2 point is you should have a buttoned cholecystostomy so that the gallbladder continues to have an occlusion to the parietal wall. Actually, sir, when we do in recent COVID times, when we do cholecystostomy itself, there are some gallbladders which are way inside the liver, way away out. But here the interface, because of a distended gallbladder, definitely makes the procedure easy. Even then, the gallbladder is preferred to be approached through the liver. So that way they say the spill is much lesser. Okay, so there are new devices, new catheters, which retain the occlusion of the gallbladder to the parietal wall also. So I think Gurshantapa sir wanted to add something.
Intrahepatic cholecystostomy, that's what you want to do.
Transhepatic cholecystostomy.
Transhepatic.
Okay,
Dadavi sir, this is a malignant obstruction with ascites with supraclavicular metastasis.
So I don't think he's...
I don't know whether if you can mention this cholecystostomy. Cholecystostomy is a time-buying procedure for acute conditions where you are going to do a definitive procedure at a later date. So if your plan is that, then you can go for a cholecystostomy. For this person, if you are not, like we are not able to do anything, patient is not willing, best way is leave him alone. Leave him alone, take care of his pain by some means. Otherwise, we will not be justified by doing anything else other than relieving his pain, because he has ascites, already he has got a supraclavicular, very young fellow, lot of lymph node deposits with obstructive jaundice. Best, otherwise, if you do cholecystostomy, which is not going to help him and it is going to leak, and the ascitic fluid also is going to leak, probably instead of dying at 6 months, he may die in 2 months. So best suggestion would be don't do anything if we are not having any facilities and patient is not willing for anything.
Fine, sir. Fine. Point is taken. Rashmi, you'd like to ask something, or can we call it a day from your point of view?
No, thank you.
Now, I think I have the privilege of calling the... Rashmi, you can stay with us. Calling the next PG from Delhi. Kana, are you with us?
Yes, sir.
Krishnaram. So I request Siddharth Dubashi sir, Jatin Das sir, Sanjay Jain sir to take over for the initial part. Then we can request the other faculty to add up to that. So, please introduce Ramakrishna about your unit chief, then your HOD, your institution, then start presenting Ramakrishna.
Sir,
Go
I am
to the invited faculty, please.
Sir, I am Dr. Ramakrishna Kumar, second year DNB from NDMC Medical College and Hindurao Hospital. Our HOD is Dr. Ratna Chopra. I am in the unit of Dr. UC Biswal, and my guide is Dr. RN Sahai. Sahai sir. I am presenting a case of breast lump. History of 56-year-old lady, homemaker by occupation, Hindu by religion, resident of Uttar Pradesh, presented in surgery OPD with the chief complaints of lump in the left breast for past 3 months and pain in the breast over the lump for past 1 month. Patient was apparently well 3 months back when she noticed a lump in the left breast while bathing. The lump was of the size of 2 into 2 centimeter to start with, but rapidly progressed to the size of 7 into 6 centimeter in the last 3 months. No lump in the opposite breast and axilla, and patient also complains of dull aching continuous pain in the left breast over the lump for past 1 month, not radiating and not associated with any other symptoms. No exacerbating factor and relieved by over-the-counter medication. There is no history of ulceration over the left breast, nipple discharge, increase or decrease in size of swelling with menstruation, fever, and features suggestive of metastasis. Patient is neither diabetic nor hypertensive. There is no history of tuberculosis in the past, no history of any chronic medical illness in the past, and there is no history of any surgical intervention in the breast or elsewhere in the past. Patient consumes mixed diet. Her sleep, appetite, bowel, and bladder habits are normal with no appreciable loss of weight, no history of intake of alcohol, and no history of intake of nicotine in any form. Patient is postmenopausal for past 10 years. Age of menarche is 13 years. Age at first pregnancy is 21 years. Total number of pregnancy is 6. No history of abortion. All are normal vaginal delivery. Last childbirth 16 years back. And there is no history of oral contraceptive pills intake or hormone replacement therapy. No history of breast, ovarian, prostate, colorectal, and pancreatic malignancy in any member of the family and first degree relative of the family. Patient underwent core cut biopsy on 17th of July 2019. Patient have not taken any treatment for this illness and no history of any drug allergy in this patient. Summary of the history: a 56-year postmenopausal lady with lump in left breast which grew from 2 into 2 centimeter to 7 into 5 centimeter in 3 months. Vague pain over the breast relieved by over-the-counter medication. There is no history of any significant risk factors, comorbidities, or features of metastasis. Patient has undergone a core biopsy, report of which is awaited.
Hello, Ramakrishna. You have
Hello,
told what is the age of the patient. Your patient is a 10 years post-menopausal lady.
Yes, sir.
And you say that your total duration of complaints are how much duration?
3 months, sir.
3 months. And you say that there is no history of increase or decrease of the swelling with menstruation. How do you correlate this?
Actually,
so this is an unforeseen mistake. Simply, I want to point out. Second thing, you say the duration is 3 months.
Yes, sir.
And a core biopsy was done in July 2019.
Actually,
so for what a core biopsy was done if patient was asymptomatic?
Sir, actually, this patient came in our hospital at that time. And
that I simply want to convey that there is something we are missing. Either you have to take it in past history somewhere, correlate. Means these things, they do not correlate and can create problems for you in the examination. That's all. So I just simply wanted to point out.
Okay, sir. Thank you, sir.
And what is the significance of alcohol in these patients?
Sir, alcohol and smoking has a synergistic effect. They are a risk factor for the development of the carcinoma of breast.
Oh, why?
Does it have anything importance in this patient? She is basically postmenopausal patient. And from where the hormones comes in a postmenopausal lady?
So basically the adrenal gland.
No. It is the peripheral conversion.
Peripheral conversion.
And alcohol increases the chances
the
of-
In the postmenopausal scenario, alcohol is important, smoking is important, or too much obesity is important for carcinoma of the breast?
So obesity is important for the carcinoma of the breast.
Postmenopausal obesity.
Postmenopausal obesity.
You have mentioned about no features of metastasis.
Yes,
can you specifically tell what is that you asked in a LABC?
Sir, I have asked the patient about the chest pain, any breathlessness, if the patient is having any pain abdomen, if the patient is having dyspnea, if the patient is having convulsion, if the patient is having any bone pain.
Which bone pain?
Which
bone pain you ask?
Just a minute.
Yes, sir.
Don't go on asking for convulsions, coma, history of death, jaundice, and all that thing, not required. The most common two organs are pleura and backache. Enough. If you ask pleuritic type of a pain and breathlessness and low backache. Specifically ask for low backache. Okay. Don't go on asking convulsions and unconsciousness and other things.
So why do you ask the history of backache?
Yes, sir.
Why? What is the reason?
Sir, because the carcinoma breast metastasizes to the bone, and the most common site is the vertebra.
Oh.
Along with the ribs, the vertebra is the most common site.
How it reaches the vertebra? The secondary is from the breast. How it reaches the vertebra?
What is the mechanism?
What is the root?
What is the root? What is the root? How it drains to the spine?
Maybe through the intercostal vessels or the lymphatics.
How many intercostal vessels you have?
I'm not sure actually how that is.
What is the drainage of breast then? Blood supply of the breast.
Sir, medial and lateral pectoral nerve and the intercostal.
Pectoral nerve. We are talking about breast blood supply. We are talking about not pectoralis major muscle supply. Okay, you are not read. Please go back because this is very basic anatomically, which is how much intercostal vessels, how is anterior and posterior, where it goes, how the asagas systems are formed, how the Batson plexus are formed, and this transportation mechanism is very important because sometimes basically we will ask questions only based on the anatomical, but you are not fully thorough on that. You have to go and prepare on that fully.
See, now one more question which I want to ask is, you have asked about the family history.
Yes, sir.
So what is the significance? Very straightforward question.
Sir, breast cancer is familial if the BRCA1 or
Very good. Very good. So how much is the percentage of this?
Sir, almost 20 to 30% patients have.
No. Familial breast cancer. It is somewhere around 5%.
5%.
So these are the very basic questions which we have asked.
And in the family history, what will you ask?
Sir, if there is any cancer associated with the BRCA1 and BRCA2 gene, like breast cancer in the first degree relative, ovarian cancer, pancreatic, GI malignancy, specifically
If her mother had the breast cancer, what you will ask for her? What you will ask for that if her mother had the breast cancer?
So if her mother had the breast cancer, then I would means that makes the patient as a high risk patient, and I would
No, that definitely makes the. What are the things you are going to ask?
at which age the mother was diagnosed?
At which age the mother had the breast cancer, and what else?
Any more details if the patient has some details, some more details if the patient had about the surgery, about the tumor? Would you like to know? Look for it.
Maybe the after the diagnosis, the progression of the disease and the treatment which she received.
Then you will ask about whether she had the unilateral breast cancer or the bilateral breast cancer. Okay, if somebody had a breast cancer which was bilateral and premenopausal age group, that has got the highest chance of having the transfer of the disease, as compared to somebody who is the postmenopausal and unilateral breast cancer is there. So these are the things you have to ask about in the family history. Yeah.
Your patient is a postmenopausal patient. You ask the history of OCP. What's the significance of that? 10 years postmenopausal, you ask, is there a history of OCP?
The long duration of OCP intake increases the unopposed action of estrogen for a long period of time.
What the OCP contains?
Sir, nowadays OCP, estrogen and progesterone.
So that is a normal cycle only. You are giving estrogen, progesterone.
OCP high. So earlier days, the dose of
especially this is a postmenopausal woman. We are not out there, but the OCP. OCP, there is evidence is very low.
Particularly
talk about the hormone replacement.
Particularly with 6 deliveries.
Yeah.
Yeah, Ramakrishna. Yeah. Are you able to hear?
Yes, sir. Yes, sir.
Yeah. Do you think it's a benign breast disease or a malignant breast disease on history-wise this lady has?
Sir, considering the age of my patient and the short duration of history, I would have high index of suspicion for the malignancy.
Yeah, any postmenopausal patient with a breast lump, clinically, you should keep a possibility of malignancy unless otherwise proved. Is benign breast diseases are common in postmenopausal patients?
Sir, benign breast diseases are more common in the adolescent group of adolescent.
Why they are not common in postmenopausal lady?
Because the estrogen level in the postmenopausal age group is decreased, and for the benign breast disease,
benign breast diseases are hormone dependent diseases.
Hormone dependent disease.
Where ovary should be functional ovaries. Okay, estrogen production will be there in postmenopausal. Is it the only ovary which is producing estrogen, or are there any other sources of estrogen in a female?
The peripheral conversion.
The organs which produce
any other secretion? Any other secretion? You said in the beginning.
Sir, from the adrenal gland.
One, adrenal. Second, peripheral fat. Fat also is one of the sources for estrogen. Okay, fine. So postmenopausal, whenever lump comes with a history of breast lump, keep a possibility of malignancy unless otherwise proved. Fine, continue.
You said it's a short duration, 3 months duration. Do you think what is the doubling time of the carcinoma of breast? How much cycle it has to undergo to develop 1 centimeter mass? Roughly.
10 to the power 10 cycles for 1 centimeter.
No. It is only almost the 20th cycle only it produces metastasis, seedling. But 25th cycle to 30th cycle, it needs to produce 1 centimeter. It takes long time. It is not a very fast growing tumor.
Ramakrishna.
About the tumor doubling time, it's about 90 to 120 days for the cancer of the breast. And to become one cell to be palpable as 1 centimeter, it will take at least 5 years.
5 years.
So yeah, at least 5 years will be there. So it means that cell which has changed into the malignant, it is 5 years back.
Right.
And then after that 1 centimeter becoming 2 centimeters much faster. Okay, as any calculation which is there. Yeah.
See, Ramakrishna, what you call a post-menopausal and carcinoma breast.
So when the normal process of the menstrual cycle has stopped, then the patient will be called postmenopausal. And
in case of carcinoma breast, 5 years after the menopause, we call it a postmenopausal.
5 years after. Okay, sir.
If it is less than 5 years, what do you call it as? If it is less than 5 years, what do you call them? If it is less than 5 years, what do you call them?
I don't know.
Premenopausal, postmenopausal,
in between.
Anything in between?
Actually, patient has stopped.
Question is premenopausal woman, postmenopausal woman. In between, do you have something?
No, sir. Perimenopausal.
Yeah.
Perimenopausal. Premenopausal, perimenopausal, and postmenopausal.
Okay. So every breast lump, irrespective of the age, has to be considered as malignancy until proved otherwise. That is the basic dictum. In these cases, in the 56 years old lady, postmenopausal, there are more probability of a malignancy. You have to think. Okay. Your history is over?
Yes, sir.
Okay. What percent is familial? If the mother is suffered from breast carcinoma, what are the chances of her daughter is going to develop carcinoma breast?
10 to 20%.
Is it calculated in terms of percentage or in terms of some fold increase to the general population?
7 to 8 fold. I'm not sure.
You know anything a Gale model, class model?
The Gale model, that's for the risk assessment of the patient.
Okay.
That takes into account the patient's estrogen exposure, patient's family history,
age of menarche, age of first child.
That's age of menarche and menopause, that complete estrogen exposure of the patient. The patient has how many babies the patient have, and had she adequately breastfed the child or not. The obesity factor is present in or not, and if there is any
Rajgopal sir, please.
Nothing, Ramakrishna. Since you had mentioned true cut biopsy done in 2019, I accept it. Can you tell me what are the strong pre-risk factors histopathologically? Don't tell me about age and all now. Pathological risk factors for carcinoma breast.
The pathological means cellular.
Pathological means somebody does an FNAC or a true cut, report comes something. That's what I meant by precancerous. Highly pre-malignant lesions.
Cellular atypia, basically high number of mitosis and cellular atypia.
Say atypical ductal hyperplasia. Yes, anything else? You should read about this. What about lobular carcinoma in situ?
So lobular carcinoma in situ generally, sir, lobular carcinoma in situ have a bilateral predisposition, and
so this is the way you need to escape in the examination. You said lady came to your institution, somebody did an FNAC, it might have come as something. That's what I'm trying to tell you. Defend yourself. They will ask you about these things. Radial scar. Have you heard the term radial scar? Not radical, radial scar.
Radial scar, sir, for.
Is it pre-malignant? It is not pre-malignant. Okay, you should read. Atypical ductal hyper. Earlier they used to call as epitheliosis in the fibroadenosis section. Yes, now it is better word is cyclical mastalgia with the nodularity. And atypical ductal hyperplasia is the strong pre-malignant lesion. Okay, yeah, please go ahead.
See, Ramakrishna, how many of lobular carcinoma in situ will get converted into invasive this lobular carcinoma?
There are about 1% of the patients will get converted.
No. If it is 1%, then it is not a pre-malignant lesion. It is around 20%.
You said no bilateral.
What is the common? Is it turned into lobular carcinoma or ductal carcinoma? We have a lobular carcinoma in situ, which will turn into a ductal carcinoma or lobular carcinoma.
So lobular carcinoma in situ. How will it turn to ductal? It will turn to lobular carcinoma.
No. Which is more chances of turning into invasive malignancy, which have got more chances. This is what he is asking.
More. So since lobular carcinoma in situ has the more chance to get converted into.
No.
Invasive.
Again, the other way around.
So now the terminology itself is in a question. Lobular carcinoma in situ is not coming under our AJCC guidelines, because the possibility, it is only telling us it is going to, breast is going to turn into malignancy. It is not going to tell you it is turning into lobular carcinoma. It is more possibility it is going to turn into the ductal carcinoma.
So now you can proceed for examination. I
Go for examination. Yeah.
Okay. General physical examination. The patient was examined in a well-lit room with adequate exposure after obtaining consent in the presence of a female attendant. Patient is well oriented to time, place, and person. Her blood pressure is 110 by 80 mm of mercury in right arm supine position. Her pulse rate is 84 per minute, regular, normal in volume. Patient is afebrile at present, adequately hydrated. Her BMI is 18.1. Performance score on Karnofsky performance scale is 90 by 100. No evidence of pallor, icterus, cyanosis, clubbing, and edema over feet and arms. There is no generalized lymphadenopathy present, and regional lymph node will be discussed in regional examination. Examination of bilateral breast and axilla. The patient was examined in sitting, leaning forward, and semi-recumbent position with arms position as required. Both breasts appear similar in size, position, and contour while sitting, leaning forward, and raising arm upwards. Nipple areola complex of left breast is deviated a few centimeters upwards and outwards in comparison to right breast. Size and shape of nipple areola complex is maintained bilaterally. No visible nipple discharge seen. No cracks, fissure, and ulcer over nipple areola complex. Axilla, under surface of the breast, bilateral arms seem normal. Inspection and palpation of the right breast is normal in all aspects, and inspection of the left breast. Skin over the breast appears normal. There are some engorged vein over the left breast. A solitary fullness is visible in the upper outer quadrant. No change in color of the skin is seen. 1 centimeter healed scar of core cut biopsy is seen in the upper outer quadrant, and no quadrant satellite nodules or ulcers seen. Palpation of the left breast, no local rise of temperature over the whole breast, no tenderness anywhere on the breast. A single non-tender hard lump is palpable only in the upper outer quadrant, extending to the upper inner quadrant as well. Size of 7 into 6 centimeter. Margin of lump is not distinct. Surface is irregular, and lump is fixed to the breast tissue. The lump is not freely mobile within the breast tissue. No evidence of involvement of skin as confirmed by pinching and movement of the lump. No pectoral muscle and chest wall involvement. Palpation of the nipple areola complex shows no abnormality such as lumps, nor can any discharge be expressed. Examination of regional lymph node. A single, firm, non-tender 2.5 into 1.5 centimeter central group of lymph node is palpable in the left axilla, which is not fixed to the underlying structure. No lymph node in the contralateral axilla, no lymph node in the supra or infraclavicular region, no Virchow's nodes. Systemic examination. Examination of head and neck, abdomen, and spine is within normal limit. CVS and respiratory system is also normal limit. PV and DRE is not done. Case summary. A 56-year postmenopausal lady with a solitary, non-tender hard lump in the upper outer quadrant of size 7 into 6 centimeter in left breast since 3 months. There is also a single firm non-tender 2.5 into 1.5 centimeter axillary lymph node which is not fixed to underlying structure without any clinical evidence of metastasis. My diagnosis is locally advanced carcinoma of breast, stage 3, TNM stage T3 N1 N0, stage 3A.
See, Ramakrishna,
yes, sir.
Your lump is situated in upper and outer quadrant.
Yes, sir.
Ram Krishna,
Yes, sir.
your lump is situated in upper and outer quadrant. See, why the lumps occur more in upper and outer quadrant?
Sir, because their maximum amount of breast tissue is present in the upper and outer quadrant. So the maximum.
Okay. Why? Why there is more breast tissue in upper and outer quadrant?
Why? Why?
Where it is going ultimately, how it extends.
So it extends into the axilla with axillary tail of spines.
Yes. So presence of axillary tail makes the volume more than the other quadrants. Second thing, you narrated about the spine. How do you test the spine? How do you examine? What do you do? What maneuver you will do whether there is no spine involvement?
So we examine the spine for any tender spots if present.
Where do you look for? Where do you look for tenderness?
Sir, along the vertebral column, along the spine.
What are the parts of the vertebral column? You know.
Sir, basically thoracic vertebra, D10, thoracolumbar vertebra.
The parts of the vertebra which can be examined, the visible on examination.
Sir, lumbar, thoracic, and cervical part.
No, parts of the vertebra I'm asking. Parts of the vertebra.
Body, then ala, and spinous process.
Which are the anatomical area which are amenable palpation? Where do you expect metastasis?
In the body.
The body. Where exactly in the body? Where do you look for clinically? Where is the site you would like to look for?
Exact.
Is it in the spinal area or paraspinal area?
So metastasis occurs in the vertebral column, but because of that, patient experiences pain and there is paraspinal spasm. So,
no, incidence of metastasis in the pedicle, which is in the paraspinal area. What you palpable is the spinous process, which is very prominent process of the vertebra. There, the incidence of metastasis is almost negligible or nil. The metastasis is more often in the pedicle, which is felt clinically as in the paraspinal area. No doubt, the muscles can go paraspasm, but you have to look for paraspinal area, this paraspinal tenderness, because incidence of metastasis are in the pedicle, which is the lateral to the spinous process.
How do you check for that? That question is he's still not answered at manure. I think Dr. Jain asked him the manure. How do you check for that paraspinal tenderness? What do you do actually?
the patient remains in the sitting position. We examine the patient from the back, from the thumb of the.
Okay. You said that on examination that distended veins over that particular breast lump.
Yes.
So what is the significance of this distended veins? The prominent veins that you said?
So, increased.
So you mean to say there's increased vascularity. So the presence of the prominent veins indicates malignancy of the breast. That's the sentence that you want to convey?
No, sir.
In which condition of the breast disease where prominent veins are more often seen? Is it in malignancy or some other disease?
So in the benign breast disease also there may be engorged veins present over the.
Come out with the answer. Which benign?
Be very specific. No? I think the specific question has been asked. You be very specific.
In the large giant fibroadenoma or phyllodes tumor, we can see the
giant fibroadenoma or a phyllodes tumor. Both are same or separate entities?
Separate entities, sir.
Okay. What is a phyllodes tumor?
The phyllodes tumor. Sorry.
What is phyllodes actually?
So phyllodes tumor is a locally aggressive tumor of the basically.
So all phyllodes tumor are benign lesions, or you do get a malignant phylloid as well?
The malignant phylloids as well. We get malignant phylloids.
But what are the criteria? What are the significant criteria on histology for a phyllodes tumor?
So on histology, I don't know.
Okay. We need to talk of the pleomorphism. We need to talk of the stroma. We need to talk of the mitosis per high power field. And the stromal atypia has been recently added by the WHO. So these are some of the criteria that we need to look for when we talk of the benign, the borderline, and the malignant varieties of a thyroid.
Did you check for the internal memory chain here? Did you check for the internal memory chain here?
The internal memory, I did not see for the internal.
How did you see that, and tell how will you see
internal
that?
Memory is clinically not palpable.
No, but
what are the indirect evidence to say that they are enlarged?
Okay, you can see that the fullness in the intercostal spaces is there, especially the second, third, fourth, fifth space which is there. You can see the fullness there. And then if you percuss in that area, there will be parasternal dullness will be there. If you find these two things, then probably the patient may have the enlarged internal memory chain of nodes may be there. Did you examine the chest of this patient?
Yes, sir.
What things you can expect in the examination of the chest of a patient with a metastatic carcinoma of breast?
In metastasis carcinoma of breast, patient may have pleural effusion.
Yes.
Patient consolidation of a part of a lung.
Right.
Chest pain. So
added only examination, yeah.
Added
what
sound.
Are the things? Yeah, added sounds may be there, yes. How will you differentiate whether it is a pleural effusion or a consolidation?
Sir, on percussion, the pleural effusion will be
both will be dull on percussion.
Yes, sir.
But how will you differentiate? You know the vocal resonance and the vocal fragmentus?
Yes, sir. In vocal resonance.
What will happen?
So in vocal resonance, in consolidation, there will be increased resonance, but in the pleural effusion, it will be decreased.
Because one is solid, one is liquid. So definitely the sound vibration will definitely go better with the solid mass which is there.
What type of breathing you will get?
Sir, in
solid,
we will get the bronchial type of breathing, but in
okay. Now, see, coming back to this internal memory nodes, which part of the breast will drain more to internal memory? Is there any sectorial drainage of the breast lymphatics?
The sectorial drainage, I have.
See, 85% of the lymph drains to the axillary nodes.
Yes, sir.
It is not that medial will drain to internal memory and lateral will drain to the axillary. It is rather the posterior part of the breast, which is near the chest, will drain to the internal memory, and then the rest part, there are more chances of the draining into the axillary node. Then you have said there is a scar of 1 centimeter of which biopsy?
True cut biopsy.
So do you want to say that true cut biopsy requires a scar or incision of 1 centimeter?
No, sir. The true cut biopsy requires a very small incision, but patient underwent true cut biopsy.
Biopsy you can say, but true cut biopsy and 1 centimeter again will not go hand in hand.
Just stab neck incision is required for the true cut. 1 centimeter is probably patient must have gone for a incisional biopsy.
Incisional biopsy.
No, go ahead.
Yeah, go ahead with that. Yeah. So how you are going to make a diagnosis here?
Sir, I would like to do a triple assessment of this patient. Clinical examination I have already done. Then on the radiological part, I will advise the patient for a mammography ultrasound of bilateral breast and mammography of the bilateral breast. And after that,
why you will do a bilateral ultrasound and why you will do a bilateral mammography?
Sir, many a times patient clinically presenting with a lump in the one breast may have some involvement of the other breast also. And if there is clinically positive axilla in the ipsilateral side, then there may have the possibility that contralateral axilla may have been.
I'm asking why you want to do both the investigations in this patient. You want to do the ultrasound as well as the mammography. I say do one investigation in this patient.
Mammography.
Yeah.
Bilateral.
Mammography in this patient. Right. Then,
sir, in the histopathological examination, I will consider a core cut biopsy.
Now, in mammography, what are the various features you get on mammography?
Sir, in mammography, we can appreciate the architecture of the breast, if there is any calcification present or not, if there is any lymph node involvement or not, and
how mammography will tell the lymph nodes?
No, sir, but all.
If you want to see the X-ray lymph nodes, what view you will do for the mammography?
Sir, mediolateral view, in the mediolateral view of the mammography.
And how do you recognize that this is a mediolateral view and this is a craniocaudal view?
Sir, mediolateral view, the axillary status of the axillary lymph node is.
No. What structure makes you to say that this film is a mediolateral view and this film is a craniocaudal view?
What structure? Sir, I don't know.
Okay, this is the pectoris major which is there. So you will see the pectoris major in the mediolateral view, but not in the craniocaudal view. And if you want to see the lymph nodes, you will do the mediolateral view for that. Right.
Ramakrishna.
What are the various?
Sorry.
Please. No, please go ahead. Yeah.
Ramakrishna, you talked something about the opposite axilla. Suppose you find a node in the opposite axilla. What does that signify?
Sir, the node in the opposite axilla is considered as metastasis.
Yes, so it will be metastasis. So will it change your staging?
Yes, sir.
Sir, the contralateral lymph node can either be from the occult lump in the breast or it can be metastasis.
Yes, I do agree. There could be occult primary in the breast which is not been palpable. There may be regional lymph node. It comes under the regional. It should be considered as a nodal disease rather than a metastatic disease.
How do you say that it is a bilateral breast cancer or it is a metastatic breast cancer?
Sir.
Okay. Somebody has a lump in both the breast. How will you say it is a bilateral breast cancer? Means both the cancer are having their natural things, or it is a metastatic breast cancer?
So through further investigation.
No, clinically, any suggestion to say that? Okay, if the lump is on the medial side, medial quadrant is there, then there is more possibility that it may be a metastatic breast cancer. But if the lump is on the outer quadrants are there, then it is more likely to the bilateral primary breast cancer, right? And then histopathology will definitely tell you that what is the nature of that.
Clinically, there is always a difficult. These are the points can be suggested.
Definitely different.
These are the points can be suggested, but ultimately, what is said the tissue diagnosis is makes the difference.
Absolutely.
और ऊपर से 100 रुपए का पेट्रोल जला कर आए हैं, ठीक लग रहा है. ऊपर से कोरोना का इंफेक्शन.
Okay, so you have done the mammography in this patient. Now what next?
Sir, after the mammography, I will advise the core cut biopsy of this patient. And
you know, what is the difference between FNA-C and FNA-B and core cut biopsy? What is the difference in the size of the needles which are using?
Sir, in core cut biopsy, we generally use 6 to 8 gauge needle. But in the FNAC,
Jailan sir, you're muted.
Hello.
6 to 8 gauge.
16 to 18, am I right? Is there a 6 gauge core cut biopsy?
I don't know.
16 to 18 gauge needle in the core cut biopsy, but
Ah.
in FNAC we generally use 24 to 26 gauge needle.
You in
No,
fact
it is around 22 gauge needle for the FNAC. It is 18 gauge for the FNAB. And it's 14 gauge for the core biopsy, the 2-cut needle biopsy, which is there. Okay. Now, when you're doing the FNAC, what precautions you have to take? How you are going to do the FNAC?
So while doing FNAC, we have to take the precaution that we will not go very deep so that we pierce the lump and go into the chest.
Okay, then
second thing, we have to take the cells from the lump, not from the other.
Then
how will you come to know that you're taking from the lump? Is there any guide you make use of it?
So we have to fix the lump, and
that is clinically.
Is patient.
Will you do a single pass or multiple passes?
Ultrasound guided FNAC is another option that we can explore.
Most of the time, it's small.
Will you do a single pass or multiple passes?
Multiple passes.
How many?
And when you are taking out the syringe from the lump which is there, what precaution you have to take? When you're doing the FNAC, I'm asking you. You do not want your material to go into the plunger of the syringe. You want that material should remain the needle of the syringe which is there. Okay, so that you can spread out that tissue which is there, because once it goes in the plunger is there, then probably you cannot push out the tissue from there.
No,
so when you're doing a very so that precaution has to be taken when you're multiple passes, and this precaution has to be taken.
As much as possible, the track should be from the skin to the lesion, where it is going to be included into the future incision if you are planning for surgery. Yes. Right? Because it is better done with your presence in the radiologist room with the ultrasound guidance, where you know how you are going to place incision. See, not all location of lumps and not all sizes of the breasts are made a standard incision. So most of the time, the size of the tumor and location of the tumor dictates, right? So you plan your incision beforehand, and as much as possible, true cut track or FNA track or whatever track, open biopsy track, be optimally included into the main surgical incision. So even if it is a little longer track or little uncomfortable for you to reach, it is preferable to include into the incision site.
Ramakrishna, you have done this core biopsy. Now, what information do you want from your pathologist from this core biopsy or histopath report?
Sir, I would like to know about the nature of the carcinoma that patient is having, the invasion, if the nature, so invasion of the lump, that is neurovascular invasion basically.
No, not neurovascular, lymphovascular.
Lymphovascular invasion. Yes. And I would like to know the receptor status, ER, PR, HER2/neu, and Ki-67.
What about aggressiveness of the disease? How do you make out?
Sir, I would like to know the grade of the
grade, lymphovascular invasion, and then
what are the criteria you look for the grade?
Sir, for the grade, we have to see the differentiation of the cell. That is, if the well differentiated cell is present or the poorly differentiated cell is present, number of mitosis, and the aplasia, ATPR. That is.
What are the specific considerations, pathology considerations, when you talk of grading, especially with reference to breast malignancy?
Specific.
Well differentiated, moderately differentiated, poorly differentiated, in general views for all. When you talk of CA breast, what is the specific grading?
What is the key component of that? In the histopathology of any carcinoma of breast, what are the findings? Very important findings you look for.
Lymphovascular invasion.
That will be there for any malignancy.
So, no.
The question was specifically with reference to grading.
Grading of the breast, grade 1, grade 2, grade 3. Have you heard about that?
Sir, yes, sir, grade 1, grade 2, grade 3, more than 75% of the cells, if that are, those are well differentiated, then that is grade 1, 50% to 75%, grade 2, less than 50%, that is grade 3.
That's what we are saying. This talking of this well differentiated, talking of the anaplasia, that degree of differentiation you're talking of. Have you heard of any specific grading system for malignancy of the breast? Pathology grading system?
Name, can you name any? Do you name any name? That's what sir was asking.
Have you seen the pathology report that comes? Have you seen any histopathology report that comes?
Yes, sir.
What does it say? The final thing, what does it say?
So it high grade or
Okay, we talk of the nuclear pleomorphism, we talk of the tubule formation, we talk of the mitosis. So these are different criteria, but is there any specific grading system which is there? You know any?
Bloomberg grading system.
It's not Bloomberg. That also was the old one, the Bloom and Richardson. Now we have the Elston-Ellis modification of the Bloom-Richardson. So it's not Bloomberg, it is Bloom-Richardson, and now we have the Elston-Ellis modification. What you need to remember is the nuclear pleomorphism. We need to know about the mitosis and the tubule formation.
Important tubule formation. You must, when you histopathology, you must not forget that word. So, what are the other TrueCut methods now? Modern TrueCut method. Any other advancements in the TrueCut biopsies you have?
Advancement in the TrueCut biopsy.
Any? What is mammatome?
Sir?
Mammatome.
Mammatome.
Rashmi, you would like to take the questions?
Vacuum
If
assist.
Ramakrishna is not answering, then you take the questions. He takes the priority.
Vacuum
assisted, sir.
biopsy. Vacuum assisted biopsy.
You want to address what is a mammatome?
But Rashmi, when you talk of the VAC, when you prefer VAC, it is not all lesion. When it's a small lesion, where there are chances of missing, then you need the VAC is more useful.
VAC is also used nowadays for for treatment of smaller fibroadenomas or smaller benign lesions. Also, you can do that. Yep.
Okay, Dr. Ramakrishna, what is HER2?
Sir, it's the receptor HER2 new.
And that's what I'm saying. HER2, you're saying. What is this HER2 actually? What is it? And what does it signify? What sort of prognosis does it signify? What is it actually? What is HER2?
So it's the epidermal.
Fine, epidermal growth factor you want to say, but what is it actually? What sort of a receptor is it? And what prognosis does it signify with reference to malignancy?
It signifies poor prognosis. HER2 receptor is positive. It signifies poor prognosis. And
okay, so it's a membrane. It's a tyrosine kinase receptor. Signifies a poor prognosis. Which are the other prognostic factors for malignancy of the breast?
Sir, lymph node status, tumor size.
That would be the most important. Okay.
Tumor size, the presence or absence of the metastasis, systemic or local, and
local factors.
Yes, sir. Please, sir. Abhay, sir.
Ramakrishna, I just want to ask you, you have this patient, let's say, forget the diagnosis, etc. It's a CA breast, 3 centimeter tumor located in the upper outer quadrant. Patient is fit. What will you do?
Sir, in a 3 centimeter tumor, it signifies early carcinoma of breast. Sir, if there is no nodes present, then I will advise the patient. I will give the option of the breast conservation surgery. And
when will you opt for breast conservation? When will you opt for an MRA?
Sir, if the tumor is to breast tissue ratio is good, and the patient is ready to follow up after the breast conservation surgery. And if the patient follows it.
तुम्हारा प्रॉब्लम एक ही है, तुम डरता है.
No, sir.
तुम कॉन्फिडेंटली बोलो. हर एक एग्जामिनर आपको क्वेश्चन पूछ रहा है, आप आंसर आधा देके रुक जाते हो. ऐसा मत करो. अभी मैंने तुमको पूछा 3 सेंटीमीटर ट्यूमर है, बाकी कुछ भी नहीं है, पेशेंट इज फिट फॉर सर्जरी.
The breast conservation.
Breast conservation, fair enough. I asked you the second question. When breast conservation, when MRM?
Sir, if the patient agrees for the follow-up, if the tumor is to breast ratio is good, if the there is no contraindication for the radiotherapy to the patient, and in the sentinel, no contraindication.
So now, see, that is what I want to stop you. You are searching for more answers. You give 1, 2, 3. I will do breast conservation. Khatam. Say again.
Sir, if the patient agrees for the regular follow-up, tumor is to breast ratio is good, and there is no contraindication for radiotherapy, I'll go for the breast.
Otherwise, you will do MRM, correct?
Yes.
Have you done MRM?
Sir, I have assisted in MRM.
Assisted. So what incision was taken? See, I am bringing you in to the system again, because I personally felt that the examiners were trying to take you away to an area which you did not know. That is what I personally felt. So I came in. So I want to know from you things that you have seen in treatment of malignancy of the breast. So if you have assisted an MRM, tell me what incision was taken. What was the position of the patient?
The modified Stewart incision was.
देखो अभी तुमको पूछा था Stewart. What is this Stewart?
Sir, basically you asked about the incision. The patient was supine, arms extended, abducted to expose the axilla, and then the incision that was taken is the elliptical incision enclosing nipple areola complex. We have to keep in mind that if the node is not positive in the axilla.
Again, you started if. You tell me the steps. Elliptical incision including the nipple. Then what you saw?
Incision should not extend in the axilla if the axilla is clinically negative. And then we will go deep and raise the flap, superior and inferior. Superior flap should be raised up to the inferior border of the clavicle, and inferior flap is raised up to the upper part of the rectus muscle, basically.
ठीक है, तुम जो देखा वो बोलो, मैं सुन रहा हूँ, सब लोग सुन रहे.
Up to the upper part of the rectus muscle or the inferior crease of the breast, and the flap which were raised should not be too thin or thick to enclose the breast tissue. Then we will have to medially we have to go up to the lateral border of the sternum. We will raise the breast with the pectoral fascia from the medial end. Then we will go from medial to lateral, preserving.
How many MRMs have you assisted?
So basically 2
or 3. When you were around the sternum, bleeding हुआ?
Around the sternum,
lateral border of the sternum, suddenly one artery started bleeding. हुआ नहीं, देखा नहीं, चलेगा, चलो आगे. Medial to lateral dissection.
And while dissecting medial to lateral, we will have to remove the pectoral fascia, and laterally we will encounter the long thoracic nerve that we have to preserve, thoracodorsal bundle that we have to preserve, and
एक मिनट है, अभी medial to lateral जा रहा है. Long thoracic किधर identify करोगे आप? I'm talking to him in Hindi. because he's from the north. Please bear with me, people who may not understand Hindi that well.
Sir, I'm happy he's pulled back to his track, sir. I'm okay with any maneuvers as an examiner you take.
Where will you, when the dissection starts in that area, you will start looking for the long thoracic nerve of Bell.
North thoracic nerve of Bell will be visible on the most lateral side along the anterior axillary fold, basically anterior axillary line in the axilla.
See, I can see all of them. Some of them are nodding their head, some vertically, some horizontally.
Sir, sir, I think I will request you to give the procedure for the benefit of all the students, sir. I think struggling.
I just wanted to know whether he is faltering because he's not well read, and
the language communication.
Yeah, because reading can be done. I'm here to see whether this man has worked in the ward.
Please go ahead, sir. Please go ahead, sir. Please go ahead. At the end, maybe you can sum up and give an exam-oriented answer, sir. Now
I am not a breast man. So even then, I know MRM steps for sure.
Thank you, sir. Thank you.
Okay, then medial to lateral, you started raising. Then you reach the axilla. Then what do you do? What structure, important structure, do you like to see and stay below that without injuring it?
The angular vein, below angular vein, we will not, in the axillary dissection, below the angular vein, we will not go. And above, we will see the subclavian.
But one big vein you saw, chalo. And you happen to be right, chalo.
Then we have to remove the level 1 and level 2 lymph node from.
When you said level 1, level 2, again the questions will come. Level 1, consa, level 2, consa. So what is the best way to get out of this?
So anterior, posterior.
Clear the axilla of entire fibrofatty lymphatic tissue. That's the safest thing for you to say. Let the examiner ask you at what stage which node comes, etc., etc. Chalo, you have removed the entire breast and the axillary tissue. How did you? What was used for closure?
So in the basically the skin is closed with a placement of the drain in the axilla and the breast bed with echelon 30.
ठीक है ना, मैं किधर ना बोला. What drain was put? What drains were used?
Jackson Pratt. It's negative suction drain.
How did it look?
So small drain with negative.
What is the color of Jackson Pratt drain?
Transparent. The belly is transparent. And
see, don't answer theory. You tell me what you saw.
So I saw closing the flap with the echelon 30 by closing the drain.
But drain कौन सा डाला? Corrugated डाला, Jackson Pratt डाला, Romovite डाला.
Jackson Pratt.
So how did it look to you?
It was a flat drain, white colored with multiple.
So that is what I want to know. Now, people who are nodding head transversely have started at least vertical nodding. I'm happy about that. So white colored flat drain was used. One was put under the upper flap. Second, you said was under in the axilla, and then 30 was used to close. What dressing did you give? Obviously, the surgeon must have left by this time.
We basically compression dressing has.
How did you give compression to the axilla?
By placing a gauze piece in the form of balls. We place the balls in the axilla and then we feed pressure.
You must have seen this patient in the post-operative period, right?
Yes, sir.
Correct?
Yes, sir.
Okay. and the patient must have been given a compression dressing. When was the compression released?
Sir, after 24 hours, the compression was released. 24 to 48 hours.
तुम 24 बोलो या 48 बोलो?
In our hospital, the dressing was opened next day.
Next. Okay, fair enough. What was the advice given to the patient after removal of this dressing?
So active shoulder movement, active hand movement of the side, which was operated. Active movement.
Active movement. Why this thing was told to the patient to do active movement?
To prevent the seroma formation. Under the flap, there may be collection of the seroma as well as the lymphedema of the hand. So to prevent the lymphedema as well as the seroma, we advise the active movement.
So you have got drains there. Drains are going to drain. What is the problem? Why do you expect a seroma in this patient? If there are drains?
Drain can prevent the seroma, but if the drains are blocked, then
Jackson-Pratt drain was white, was flat. Tell me number of holes in the Jackson-Pratt drain.
The number of holes. That was
you are expecting blocking of the drain, and you are using one of the best drains available for breast.
Many have not seen it, sir. Many have not seen it. I will like you to elaborate. Many have not seen it.
It's a flat drain with multiple small openings. There are more than 50 to 60 openings in that, unlike a Romovac.
Yes, and very soft.
So it's very unlikely that the entire Jackson-Pratt, and you're putting two of them, is going to get blocked, and the patient is going to develop seroma. Okay, how do you charge that Jackson-Pratt drain? It's also known as flat drain for benefit of PGs.
Yes.
After the compression dressing, if Jackson-Pratt drain has two holes, one hole should be covered, and then negative pressure will be applied, and the other one. There are two openings, two port of connection. One will be connected, dressing will be done, negative section will be applied, and other will be closed. Then the negative section will be.
Okay, fair enough. Dubashi Sahib, you can take over. Be gentle.
Ram Krishna, yes, you open the dressing next day. What is your first idea to look at it? What do you want to rule out?
Sir, if there is any flat necrosis present or not, after opening the dressing, first thing that.
What are the minimum number of lymph nodes that we remove to call it an adequate specimen?
The minimum 10.
10 to 12 nodes, that's fine. Are you removing all the three levels, or you are removing only first level?
The level 1 and level 2 is removed.
Okay. What is the indication for level 3 then?
So if in the case of a clinically positive axilla, level 3 lymph node should be removed.
Clinically?
Positive axilla. If the lymph node is palpable clinically, okay, like in this patient, central group of lymph node is palpable, then in this patient, level 3 group of lymph node should be removed.
What are the drawbacks of taking out the level 3?
So, high chance of lymphedema of the arm.
Okay.
And
it corresponds to what anatomical name of the lymph node? Level 3.
Name of the apical group of lymph nodes.
Yes, apical group of level 3. But how do you assess the prognosis on the number of lymph nodes?
Pardon, sir?
How do you assess the prognosis?
Sir, if the level 3 lymph nodes, means the farthest lymph node that we remove comes out to be negative, then that is a good prognosis. But if that comes out to be positive, then we know that it is progressed far beyond. So that's the poor prognosis.
Okay. What are the contraindications?
Your case is early breast carcinoma or LABC?
The locally advanced breast carcinoma.
Okay.
Is this operable or non-operable? What is operable LABC?
The T3N1 is operable LABC. After the T3N1, it's non-operable.
So this is your operable. Well, straight away you can go for a surgery.
Yes, sir.
So post-operatively, what do you do?
Sir,
Adjuvant therapy.
Yes, sir.
Suppose you say there is a few nodes are there, positive, ERP are negative, and how are you going to proceed with that?
So ERP are negative and nodes are positive.
Yeah.
Sir, we will have to give the along with the adjuvant chemotherapy, radiation therapy to the axilla.
So you already done a surgery. You will give again radiotherapy to the axilla. You already done the axillary dissection.
Sir,
will you give again radiotherapy to the axilla?
I didn't understand the question actually.
You are already done the axillary dissection.
Yes, sir.
Now you say again you are go for radiotherapy to the axilla. Is it justifiable?
Chemotherapy, adjuvant chemotherapy to the patient. And ERP, since the patient is ERPR positive, I would like to add the hormonal therapy as well.
Suppose ERPR is positive, which one you will start first? Chemotherapy or hormonal therapy?
After completion of the chemotherapy, hormonal therapy will be started.
What chemotherapy do you give to these patients?
So in these patients, we follow the CAF regimen, cyclophosphamide, adagrasib, and 5-fluorouracil.
Say again.
The CAF regimen, cyclophosphamide, adagrasib, and 5-fluorouracil.
Right. Ramakrishna, one question from my side.
Yes,
if you have a locally advanced breast cancer, as you said you had, about 7 centimeters in size, what is the treatment that you would recommend? It is now confirmed that it is a ductal carcinoma. What is the treatment that is advised, advocated? What is the ideal treatment that you should go for?
First, this patient should be given a neoadjuvant chemotherapy. After the neoadjuvant chemotherapy, patient should be taken up for surgery. And
now, just a minute. So yes, neoadjuvant chemotherapy you have given. Yes, when are you going to assess this patient again, whether he is responding or not responding?
So after 2 cycles of the chemotherapy.
After 2 cycles, you will assess. And what do you assess?
Sir, we assess if there is any regression of the size of tumor or not. If there is any regression.
Okay, now you have 2 options. Either the size is regressing, and the second is it is not regressing. So if it is regressing, then you do what you do.
Sir, if the size is regressing, then we continue the chemotherapy. And if the size is not regressing, then also we would like to give 1 more cycle of chemotherapy to the patient and assess again. And then also if it's not responding, then we will go plan the patient for the surgery.
Right. Suppose this has responded very well to the chemotherapy and the tumor has gone down, shrunk to about 2 centimeters in size. What surgery are you going to do?
Sir, if the tumor is reduced to the 2 centimeter size and tumor is to breast ratio size is good and there is no contraindication for the radiotherapy, then apart from MRM, breast conservation therapy can also be offered to these kind of patients.
No. What are you going to do? See, this is a very simple, it's your patient. So what are you going to do?
We will plan for modified radical mastectomy.
Right. Do you think, why do you want, the patient says, no, I don't want my breast removed. Then, so the first thing that you do is, in this patient, you say in the exam that I will counsel the patient.
Yes.
That is the first thing. But both things can be done. An MRM can be done as well as a BCS can be done. But what are the problems with a breast conserving surgery in this? There are recent trials that have been held. Any idea about them?
Yes, sir. There is a high chance of local recurrence in case of breast reconstruction, breast conservation surgery.
Yes. So, yes. So there's a high chance. It has been shown now. There's a high chance of local recurrence with the breast conserving surgery. Therefore, you will go for a MRM. Right.
Ram Krishna.
Yes, sir.
I have just one question. That if you are planning an MRM in an operable LABC, why you want NACT?
Sir, NACT reduces the stage of the patient and it increases the it increases the radio sensitivity of the tumor. So after the NABC neoadjuvant chemotherapy, the morbidity of the patient will be low as the tumor size if reduces after the neoadjuvant chemotherapy.
It is T3, no, according to your 7 centimeter.
T3, yes,
T3.
T3.
All
So
T3
early breast
lesions-
carcinoma also you give the neoadjuvant therapy, no?
Sir?
Early breast carcinoma also you can give neoadjuvant therapy.
In early breast carcinoma, neoadjuvant chemotherapy is not advised.
No, that is what your question asking. It's LABC operable. What is the purpose of giving neoadjuvant therapy? If there is any role, then why should it is called as a operable NABC?
So because we can take this patient straight to the straight for the surgery. That's why.
So I think we have another 2-3 minutes to wind up. Ramkrishna, I think I should give the opportunity. Do you like to ask any questions or you want to clarify any doubts to the examiners?
The indications of sentinel lymph node biopsy in a clinically negative axilla.
Siddharth sir would like to take this question.
Yes.
This question is, he wants to know in a clinically node negative axilla, what is the role of sentinel node marking or sentinel node biopsy?
Yes, especially see if you're planning a breast conservative surgery and if your axilla is clinically negative, then there is a role for a sentinel lymph node biopsy, and we are using the azosulfan blue dye, and we would have around 2.5 to around 7 ml of dye which would be injected. Usually we use the peritumor method of injection of the dye using an incision between the pectoralis major and latissimus dorsi muscle. So if you are planning a breast conservative surgery and if you are clinically negative axilla, there is a role for sentinel lymph node biopsy.
Thank you, sir.
Anything else, Ramkrishna?
No, sir. Thank you, sir.
I have one question, sir.
Yes, Rashmi.
So they tell the chemotherapy for LABC, that neoadjuvant we give is to prevent the systemic metastasis. The surgery is for local disease. So, but still we can go ahead with neoadjuvant chemotherapy for LABC, so local advanced breast cancer.
That is the advantage of N1 nodes. When you have only N1 nodes, you can do without giving systemic therapy. You can start with them. Then post-operatively, we are giving all the drugs. There is no need to give pre-operatively adjuvant chemotherapy for the case with you have just N1 nodes.
Any other question? Abhay sir, you are with us. As usual, your closing words.
I can only say one thing for all the people. Surgical jaundice is a different ball game. Any abdominal case is a different ball game. Quite easy to get through. Local organs like breast, lymph nodes, etc. are extremely tricky, especially CA breast. One has to know the anatomy of the breast properly, the pathology that you're dealing with, the pathologic anatomy and its behavior, the investigation and validity of the investigations that you are talking of in this particular patient, and the treatment. Because there are multimodal investigations, multimodal treatments which are available. You got to be very, very clear what you are going to do with this patient. Ramakrishna,
yes,
the
sir.
problem with you was you were not sticking to your patient. You were going away from the patient all the time and trying to talk theory and then adjust yourself. This gave an opportunity to the examiners to ask you more questions than usually that would be asked in a case of CA breast. So for all PGs, CA breast is a case where you examine your patient, have everything properly laid out, what you are going to talk in the examination when it comes to investigations and treatment, and have reasons for it. If you have adequate logical reasons for why you are doing this in this particular patient, it should not be difficult to clear the examination. Thank you.
Jailal sir, you would like to give your closing comments?
Yeah, but today, I mean, both the kind Ramakrishna, you need to study, as rightly said by Abhay sir, basics of anatomy and pathology. Because cases like this, breast, when it comes, and even a small mistakes will not be tolerated. And NCCC guidelines is the mandatory guidelines which we follow. So you must ideally stick on to them. So many times you have contradicted your own statement. You said initially radiotherapy, then giving the radiotherapy to the axilla. And many incidents it was quoted. And initially you said LABC, then again you are going for an lesions. And totally there is little more homework you need to do. Because by history, we see this case was done long back case. It was in 2019 case. So it was an old case. You had enough time to prepare for the case. And you should have little more homework you need to do when you are coming for a presentation to this case. Please go ahead.
Thank you, sir. Siddharth, sir, your words.
Yeah, as Dr. Dalvi sir also said, that all the students, a general message, we cannot ignore our anatomy, physiology, and pathology under any circumstances. We need to follow a chronological order when we are presenting, and don't contradict your own findings. And when you talk of our management, it is usually management pertaining to the case which you have got in the examination, and we don't have any general comments. And especially certain statistical information, if you do not know it, please say you don't know it. There's no point in beating around the bush and throwing any magical figures. It creates a very bad impression. But it was a pleasure to be a part of this forum. Thanks to Dr. Prabal Nyogi, Dr. Abhay Dalvi sir, for getting me into this particular forum. It makes you wiser. The first presenter, of course, did a fantastic presentation. Second, Dr. Ramakrishna, we really appreciate that you came to this forum and presented, but we need to get certain basic information right. But do keep presenting, and I think a long way to go. Thank you very much.
Thank you, sir. Thank you. Ishwar sir, your words.
When you are presenting a breast case, it's almost diagnosis is confirmed all the time. So there is no point in telling the cause. More expert students to know a lot of theory about that, because a lot of controversies and gray areas are there for the postgraduate level. Sentinel node biopsy, contraindication, implications, and other things. Then, as I said, locally advanced and locally operable breast carcinoma, you need to have your concept very clear. Because majority of the exams are interested to know these things. Because staging and diagnosis invariably is almost written on the face of the patient. So whenever representing for the breast case, so I need to expect the grading, staging, then later controversy area, what is the gray zones are there, what are the limitations of this modality. I need to expect from the postgraduate level much more than what Ramakrishna presents. No doubt he has read theory, but he has a difficulty in expressing and other things as far as the breast is concerned. Abdomen, as Dalvis has said, it can get away well along with by giving so many differential diagnoses and other things. As we know, is all Pandora's box. Anything could have been possible under that, and then Rashmi has done fairly well. I expected her to do much more better than that, generally. Then I wish both the candidates to all the best, and I would like to thank Kanagavelu sir for giving me an opportunity to be part of the faculty of this wonderful PG teaching programs. I love to be part of this. So hope to have a continuous in future. Thank you very much once again for giving me an opportunity.
Yeah, I could see ASA Hubli behind your face. I'm happy to know that.
Yes, I'm sitting in our department.
Yeah. Sanjay sir, your words.
Thank you. Ram Krishna and Rashmi. What I would like to see that you see, this is not, you will not be appearing for MCH of the oncosurgery. This is MS surgery, where the general basic concepts are to be there. Like you were confusing again the purpose of NACT. See, any anterior therapy, our main purpose is to downstage the tumor. Don't go in this thing of multiple trials, which are so many controversies. So need not go into depth, but the very basic aim of what we are doing. And of course, breast is something where you are supposed to know a lot. And what I will recommend that you can suggest you for further reading, like the clinically negative axilla or the radiologically negative axilla. What these are the things which are just in your mind, so you can further read those things. But overall, the thing was good. Ramakrishna was simply you were knowing many things, but little lack of confidence, which of course will come when you present more number of cases. This is not something which can be learned without exercise. And I thank Dr. Kanagavel for inviting me. It was a brilliant discussion and nice to watch everyone.
Unmute, sir. Unmute, sir. Kanagvel, sir.
Prabal sir, I could see you in between with the space suit, and now I think you are in between cases. I think you were there for the second part of the presentation for the day. Do you have any comments to make?
Yes, yeah. In fact, I was live streaming on the first case as well, and I heard the whole case in the OT while it was going on. Two things. One is about the second case, the CA breast. Now, CA breast is a difficult case. There's no doubt about it. There's so many intricacies in the treatment. I feel that the students should just say what happens in his institute, what he has seen. I think if you do that, you will be safe. Not only that, your internal examiners will also save you then. That is one thing. The other thing, of course, you should know what is going on, what is the right ideal treatment, but that is important. For this first case, I was a bit disappointed with the discussion because I would blame I don't know, I shouldn't blame anybody, but it did not go in the right path, the discussion. In any MS examination, what we are to do is what is a diagnosis and what is a differential diagnosis and what brings you to that. It's a very, very stepwise thing. And once you've got a set of differential diagnosis with investigations, how do you prove your diagnosis? And then finally it goes to. So I feel that the examining pattern was a bit lopsided once you go from this way to the other way. So probably a more systematic examining, I would say, would have been better, this thing, in the obstructive jaundice case. But overall, both students did well.
Thank you, sir.
So Sanjay, yeah, good.
Dr. Kanagvel, there is complaints from our fellows. And if you remember, you told us that we are discussing these cases in the classroom setting, not in the examination setting. So what happens when we are discussing, there's the knowledge, there's an ocean of knowledge. So when you also go slight laterally when you are in the classroom discussion, not in the examination. Examination, it is the index case which you ask, and there is a limitation of time. So that is why probably the examiners might be going here and there and trying to rather circumvent their knowledge and bring it all together, which was not gathered, which was haphazard. So this is probably, otherwise the thing is okay, and it is up to anybody's own decision and things. Thank you.
Sir, Sanjay sir, your points were discussed in the earlier forum very much. In fact, we were thinking to curtail to exactly 30 minutes. Then what really happens is this type of freeboarding of or allowing the examiners to move into other areas definitely puts a different, unique challenge to the PGs who present. But in the bargain, they end up learning more things because all the examiners here give the answers. If you can see, everybody, when they ask a question and they don't give the answer, the student is not unable to answer, then they definitely give the answer. Actually, so this is a different format which I hope all of us have been presenting in the general clinics, which happens monthly once in our hospitals when we were PGs, where all the unit chiefs, 7-8 unit chiefs will used to sit, and it will be banging for all of us. At least for me, it happened to be. So banging in the sense that stimulated us to work on more and more. And in fact, more faculty, see, 7 chiefs studying for what case we are going to present and coming is definitely a challenge. Even now, I would say I will scare that moments where 7 chiefs alternatively putting question back questions. But then, sir, that place me where I am. So I could definitely always be pushed to read more. So that was the idea of this class. But still, I'm open to experiments, or I'm open to suggestions telling, sir, you try to take this class this way. See, if you're going to toughly go, like we can have 1 long case and 3 short case and 1 hour we can finish. I don't want to waste the wisdom of the senior faculty here for that type of pattern, sir. But again, I'm sure students are put to more stress here in this forum, no doubt about it. They are tested in and out. In fact, couple of weeks before varicose vein, I would have said even an MCH vascular candidate would have stood that thing. But I appreciate the candidate was able to cope up that much drilling. Even the soft tissue tumor, it was more than an MCH oncology. But I think maybe your point is taken, like we have to strike a balance between these two. Maybe let me take the input from the other seniors as well, sir.
we have to get used to this system of examining now, because our MS that is going to be through Zoom, and also RRCs. If Dr. Abhay would, I think, maybe the better position to tell us that the RRCs will now be held. All the RRCs in all the zones all over India will be now through Zoom with 4 examiners and people registering for that, and they'll get in. We are trying to work out through the ASI for the more number of people to join in. That is a special deal. Probably Dr. Abhay will probably be able to tell us more about it. And then we'll take it from there. Probably it's going to be a platform with a much larger number of people.
Sure, sir. Sure. Andare sir, would like to add before we call it a day?
Yes, sir. I think the extended sessions give us enough questions to gather. The PGs, one of the advice given in chat box by Dr. Sahai sir is that the candidate who has presented can go through our YouTube channel and see what the questions were asked. He can prepare himself the answers of the same and go back again to his PG teacher and present the same case again or the similar type of case again. This happens. What has happened is that up till now, majority of the students have performed extraordinarily, knowing that this is the case. So they have been preparing for 1 week or so. But the situation is different on the border. When it comes to the PG exam, they will not be knowing exactly what is the case. So, and that the time limit is also there. So majority of the examiners are trying to, depending upon the efficiency of the students, majority are trying to pace up or slow down. Today, I think of all days, I have learned the rhythm of examiner from Dr. Sanjay Jain sir. He is asking very, very softly. The candidate also should learn how to answer. If everybody of us can cope up with the pace where Dr. Sanjay Jain was asking, it was absolutely fantastic. This is what I need to learn as a teacher also. And I hats off to you, sir. You were absolutely calm and cool, so that the student was not in any hurry to answer. The students in general need to give a pause before answering. They need to listen to the questions. Both the students were good enough. Of course, there can be here and there, and all days are not similar. But every student who presents here will definitely be benefited, that I am telling you. And it is better that they go through the video recordings of their own, as well as better presented cases in past, and everybody can learn. This is the best way. I think as an examiner also, everybody is of different mentality. And I will appreciate today's Dr. Sanjay Jain's attitude, absolutely calm, as if very senior most professor is taking a UG exam and he is so polite. This is what I like to say. Thank you very much, sir. Ishwar sir, we have been at Ahmednagar together.
Yes, sir. I remember, sir. Co-examiner.
Is that, sir, your words about this pattern? If you would like to share something? I think audio is not with. Siddharth sir, are you with us?
Yeah, I'm there.
You would like to share your viewpoints on this pattern of having it, or you would like to change the pattern?
So regarding the pattern, yes, I feel there should be a time limit, but not 30 minutes would be too less, considering the quality of examiners that you have chosen. Yes, everybody would like to give in their inputs, and for the benefit of the postgraduates to make it an effective teaching program, we could have around 45 minutes to 50 minutes per case, and we could then have 2 long cases. That's what I feel. But there should be a time limit.
Make one more short case also presentation. Short case. Please include short case.
Sure, sir. Rajiv Sahai sir, I think it was his unit, his hospital case. I don't think the boy is under his unit. Sir, are you with us, sir? I think he has left. So with that, I would request the faculty can suggest more faculties who have not represented here. Any of your friends across the country, I'm okay. So in fact, that will help us to improve upon, because I think this is the 3rd breast case in this forum. The discussions have been dimensionally different, and I don't think there were much of repetition, and the students definitely stand to benefit. I think even we have another 10 breast cases also, we will have the benefit of different angles of discussion it can go. But I agree with everyone that these videos are permanently available in our channel. get back to them, view them before coming to present. And in fact, I thank our chief, Professor Gunasagaran sir, T. Gunasagaran sir. When we were residents, first year residents will have to take evening classes for the first clinical year students, undergraduate students. Second year residents will teach the second clinical year students. Final year MS PGs will be teaching the final year MBBS students for evening classes. So somehow or other, we will be pushed to, because those questions from the student will be very embarrassing when young ones ask you and you don't feel like you're rightly answering. So that was another opportunity the PG should use, especially in medical colleges, in the evening classes. When you face your juniors, you are pushed to study hard. This was one other way we were brought up in our colleges. I hope more ideas will come in and we will work on more. Andare sir, please.
Learning is teaching.
For breast case, I like to advise Ramakrishna that you must assess the CA breast case as stage-wise disease, and you must be prepared for the questions which are going to be asked in general, basic, and to little higher level, and then advanced. If he can prepare stage 1, 2, 3A, 3B that way, it will be better presentation overall. He must know what an MRM is or what is that. He may not know the advances of flaps and all this. That's maybe pardonable, but he must know what an MRM is, what is to be preserved when the structures come. This is what I believe.
Point is taken, sir. I think the afternoon part of the thing is also transgressing into our classes much. I think evaluation part of it and the operative surgery part of it, I think we are okay. But I think we'll have to have some time cap as maybe an hour or less than an hour for each case, and we will try to wind up. So the examiners have some limitations on the time also. So we will try to do that, sir. And I'll be again requesting your PGs to present cases, and you also should suggest more faculty. Of course, the core team is always there to as a spine, but we would like to explore into areas of underrepresented part of the countries. Prabal sir, Rabai sir, anyone, any senior faculty here to contribute both the faculty side as well as the PGs to present. In fact, Ajay Khanna sir left early, but he said he wanted a parotid case. Parotid case, unfortunately, I could not locate in a short notice, but I think next class we will have a probable parotid. And PGs were also asking whether we can tell the cases one class in advance so they can also come prepared. So I still have challenges because one candidate, I don't want to tell the name or the institution, they last minute in the evening recused. Ram Kumar was not given adequate time. To be honest, it was, I also contribute to his challenge because yesterday evening only I notified him and he was gracious enough to agree. So someone recused themselves in the last moment. These challenges are still happening. So at this moment, I may not be able to advise regarding the next class cases in a previous class case, but I will still strive hard to try and tell what will be the case for the next class. Because some faculty, today also a couple of faculty, even Vivek sir continuously for the second class, he could not join. They have different challenges. So let me work on it, sir. Please help me out. Please throw your ideas. Anytime you feel like, call me or send a text. I will definitely look out to improve upon, sir. Can I, Abhay sir, please.
See, I know that it's extremely difficult to get a case for a PG student, but as I can suggest to you, you can have what is known as a virtual case. So basically in RRC, we have what is known as a virtual case, that a candidate is told you are going to present right iliac fossa lump. The patient's abdomen may not be shown at all, but the candidate comes prepared, say with a CA-cecum or a appendicular lump, and presents it in such a way that the diagnosis is reached. So even if you don't have live cases, you can actually give cases to PGs saying that tomorrow is right iliac fossa lump, you prepare a virtual case and be ready. The second case, I can tell you right now, I have a list with me. Yes, we have still missed out on portal hypertension. We have missed out on CA stomach as a lump in abdomen. Then we have obstructive jaundice we have done. Peripheral vascular disease, I believe we have done only one, and that too with a blackening of toe. You can have a peripheral vascular disease with an ulcer. Yes, again, a virtual thing which can be detected. Ventral hernia is one thing which we have been missing.
I have a case waiting. I have a candidate ready.
Questions which come up in a case of ventral hernia.
Sure.
So one person can present a 4 centimeter ventral hernia. The other one present maybe a 8 centimeter or a 10 centimeter, where then the discussion can go in a different direction.
Sure.
We have yet to discuss testicular swelling, possibly a renal lump. And there are many. I'll get in touch with you, but right now I'm giving you 6, so 3 sessions are through. So whoever is interested in presenting, he need not go searching for a case. He can think that I'm going to present this, and then the examiners, I think, are handy to deviate away and take him somewhere else or ask pertinent questions. That's the way my suggestion to you would be. So we'll complete the gamut of surgical cases that are usually put up in an examination.
Sure, sir. Let me work on the 6 cases, whatever you have told for the next coming few classes. Is there anything we'd like to add? Reshmi, you have been all the time with us. You want to share something?
No, sir. If provided, I can present one more case, sir.
Maybe not immediately. I will keep you as a reserve request. Abhay, sir.
I will later present one more case if she tells me alternate name for clubbing. Find out.
Okay.
Find out. Come next time and give me the answer. There are about 7 names, synonyms for clubbing. 7. But one of them at least you should know. I'm not asking you hypervascularity under the nail. All that I know you will answer.
The low bond angle which Sam.
No. That is an angle. I want the name. It's okay. Doesn't matter. Just to. Okay, I don't want to digress. Otherwise, Prabal will again immediately say you are digressing from thing.
No, sir. Hypertrophic pulmonary osteoarthropathy.
No. That is the last stage. That is the last stage. What is that nail known as?
Drumstick nail.
Drumstick
nail.
Very good. So now you have to find out what is the synonym for clubbing. Okay.
Okay.
Doesn't matter. You're good. I like to challenge people like you.
Okay.
Okay.
Reshmi, I think maybe another week or 2 you leave a gap. Come up with any other case Abhay sir has told which are yet to be presented. Maybe testicular tumor or anything like that.
No. Give her a case which I know the best. Huh? Don't give her any urology case and ask me. Apart from adrenalectomy, doing adrenalectomy, I don't know anything.
Sir, we have done case, sir. We have done bilateral adrenalectomy in our unit.
There you are, sir.
I'll have a private session with her now.
No, sir, please give her one more opportunity. She's good. She'll present.
Sure, sir. We will definitely consider. Sir, there has been other requests from the PGs. Yes. Sir, evening time, say late evening, 9 to 9:30, like that. Every day, one procedure videos can be made as a presentation, so that we will know how to do the more recent procedures. How to work about it, sir? Am I to experiment at this point of time, or we can try little?
What procedures are you talking about?
Sir, they want to know how to do a standard thyroidectomy, how to do a standard mastectomy, like that. Video. Right.
Now, I'll just 1 minute. Those are the cases that are given for operation. But your ASI, through its, of course, but that is going to be a long process. If ASI is going to do it, when I think it's going to start very soon, and that time is in the evening, 1 hour. But those are basic surgical procedures which are done in the ward. They are going to do it. So just ensure that the time does not clash, because they are also planning to do it at 9 o'clock. I think Dr. Santosh will be able to tell us more. I think it's between 9 and 10 that they are planning to do it. So
this happen every day, sir.
But that is a minor procedures. So bladder catheterization, dressing.
Is it going to happen every day? I'm asking, sir.
Yeah, those are minor procedures. Yeah. So I just basically the time does not clash. Make sure the time does not clash.
Sure, sir. Sure.
Kanak, I think I will come back to you on this.
Okay, sir, I will wait.
9 to 11 is the time which ASI has completely reserved for the RRC, which also includes procedures.
Yes,
we go on record. Even we have actually discussed with the director of academics. I have, as a vice president, I am in charge of RRC and all academic programs. I have to decide with the academic director. And let me be very clear, everything has been decided between 9 and 11. We will be continuously, almost every day, be on Zoom from 9 to 11, starting somewhere around end of May and starting June, right up to September or October. So since you are running this and I'm happy with the way you run it, whatever we will not cover, you cover, not an issue at all.
Sir, feel free to throw the challenge, sir. Let me work on it.
I'll tell you, the reason why PGs are asking you from 9 o'clock onwards is that most of the times PGs are very busy around this time. As Corona goes away, they will be working in the wards. Right now they are free. And they finish their rounds around 8:30 or something. And then they present whatever ward rounds to the bosses. And they're only free around 9 o'clock, then free till 11 o'clock. That's how we had thought of going. I think you have echoed it quite nicely, that PGs want it around 9 o'clock. So we'll work in tandem. ASI will not come in your way of propagation of education. And I'm sure you are also in the same boat that you will not come in the way.
Yes, sir. Sure.
So
Hello, sir.
Yeah, go ahead, Rashmi. Tell us.
Sir, is it acropathy and Hippocratic names?
I saw you are looking down in your mobile through Google.
No, sir. No, sir. I was just thinking, sir.
So it's okay to look into the reference file. It's okay.
Even Abhay looks.
I have to look. My age is not to study, my dear Andarya.
No, sir. Just kidding.
In fact, I like to become examiner only to know what are the latest things. That's why I enjoy Prabal talking of recent advances, recent publications.
Sir, in one class I said that if I am to be appointed as an examiner, I should be informed 1 month prior so that I come with up-to-date knowledge if I am ready to read.
I should be told in the morning. I am not prepared at all. And I listen to the students, other examiners. I can learn quite a lot and better.
Of course. Yes, sir.
Anyway, so Kanakbhai, I think we'll get in touch with each other.
Yes,
and we'll sort out.
Please, sir. Please. As you say.
Now, the issue with standard operating procedures like say paradidectomy, hydrocele, etc., is streaming an operation on YouTube.
Okay, sir.
It's going to the problem. So
Okay.
we are working out, then we can share operations, not an issue at all.
Sure, sir. Thank you, sir. Can we call it a day, sir? With the permission of the faculty.
Pleasure.
Bye.
Bye, sir. Bye, sir. Thank you, sir.
Thank you, Rashmi.
Bye, sir.
Thank you very much.
Thank you, sir.
Bye-bye.
Thank you, sir.
Sorry, sir.
Sanjay Jain is as calm in ASI head office as he was today.
Oh, sir.
Thank you.
Thank you, Dalvi sir. Thank you, Kangal sir, for guiding
sir.
the students.
Thank you, Andarya, sir.
Thank you, sir.
Thank you, Ishwar, sir. Jailal, sir. Thank you.
Always be clear for Kanakbhai, sir.
Thank you, sir. Thank you so much.